We're recording, so you're now being recorded. And then I'm going to open the room. And I'll let the participants come on in. So we are going live now to the room so the attendees can start joining. So we should start seeing that populate in just a moment. And then I'm going to go to Facebook and I'm going to get all of that done. And I will be with you all in just a moment. Actually, we'll let people know that they're in the right spot by sharing that screen, and they will get the entry. And I will take this. Yep, let's get you over here. Over here. Oops, what happened? And this goes here. And welcome everybody. We're going to be going live in just a moment here. We're just getting our Facebook community. What happened? Hold the thought. I don't know why that's doing that. 1 second and we'll get started here. It's always fun trying to do your tech stuff and your live events simultaneously. Copy. Paste. There we go. All right. And we are streaming on Facebook Live now as well. Okay. I'm going to stop the share for just a second, and we have a number of participants who are joining us now. So good evening, everybody, and welcome to this stop of the HCMA's Bighearted Warriors UNITE Tour. We are in Utah today, but we're not because it's COVID times and it's 2020, and I'm in New Jersey. Amy Mann, our meeting coordinator for the Hypertrophic Cardiomyopathy Association, is in Connecticut. Julie Russo, our volunteer coordinator, is in Bethlehem, Pennsylvania, and the rest of these fine people are in Utah. So we are coming to you from a number of different locations. I am going to put up a poll for those of you who are joining us in the Zoom room, and that is a poll to let us know where you're coming from and what you're going to be coming up. Hello. It's been a long day. What you're going to be experiencing or what you have experienced in the space of HCM. So we know if we have patients, if you've had devices, medications, surgeries, etc. And when I conclude my talk, we'll go back over the poll. So you can all take that poll right now and throughout my first talk. So I'm going to go this way and that way. So we are going to hear from Ashley and Stacy. Do we have Ashley and Stacy with us? Ashley and Stacy aren't here. Have we lost Ashley and Stacy? Are they in the participant room? Hold on 1 second. Ashley, Stacy, I thought they were going to do our opening, but I don't see Ashley or Stacy in the room. Omar, are we waiting for them or are they not coming? Hi, Darko. Your favorite doctor's here, Amy. So Omar, do you want to do the intro? Because I don't see either of them here with us.
Sure.
Okay, so all to you. So you go ahead.
No, go ahead.
No, I'm gonna let you. They were supposed to do an intro.
Oh, okay.
And I don't see either one of them here. I'm not sure what happened there because we have Holly and Ivana and not those two. So maybe there's a technical issue with them getting in. I just noticed that they weren't here. If Ashley or if you guys are in the participants, nope, they're not over there. I don't see them. So you could give us the intro that they were going to give us, Omar.
Well, I'll give my intro. Well, okay. Thank you, Lisa. Thank you, everybody, for being present in this conference today. Thank you for the invitation. And Lisa, thank you very much for all, for your strong voice, for all the advocacy that you have. in the HCM world. It's really greatly appreciated. So as you know, Lisa, the University of Utah is one of the top academic centers, not only in the state of Utah, but in the entire Mountain West. In our program here at the university, we have a mission with 3 main objectives, which is 1, provide excellent patient care. 2, provide education, not only to the future generation of ophthalmologists, as you call them, but also to our patients and families. And 3, investigation. So we're really honored to be here today to fulfill one of those missions, trying to educate patients, families, and some of our colleagues in the community. So with me, I have Dr. Craig Salzman, who is the Chief of Cardiothoracic Surgery and the Surgical Director of the HCM program at the university. We have also Dr. Jared Bunch, who is the Chief of Electrophysiology, and he'll be teaching you interesting stuff about the management of atrial fibrillation today. We have also my partner in crime, Holly Andrews, who is our physician assistant dedicated to the HCM program, and Bryden, who is 1 month old now. We have also Ivana Grobelja, who is our genetic counselor, and he'll be sharing with you some tips about genetics in HCM.
Fantastic. So I guess I'm going to get this kind of kicked off with a little bit of a talk on HCMA and what some of the stuff that we're doing. So I'm going to do a screen share here. And I'm assuming Jared's joining us shortly. So if you could double check on his location and make sure that he's here on time, I'd appreciate it.
We'll work on it.
Okay, you get that going. Okay, so let me move this over here and that over there. And I am going to begin the night by going over our agenda. We're going to be hearing a little bit about what's going on here at the HCMA. We're going to do an oh, I have that's what, I'm sorry. It's the Utah thing. I have Intermountain's agenda up here. I am so sorry.
Competition.
I'm like, what is going on? I have a headache today, guys. I am so sorry. Wrong agenda up, but right people here. So that's the important thing. I'm like, what is happening here? So sorry about that. So I'm just going to jump past that one. But I will say thank you to our sponsors, Myocardia, Cytokinetics, Boston Scientific, and Invitae. That's over here. Look at this side of the screen, not that side of the screen, because it's been a really rough 24 hours for me. So I apologize. I want to talk a little bit about, so today we're going to be talking about electrophysiology. We're going to hear from Dr. Bunch about atrial fibrillation. We're going to talk about cardiac surgery. We're going to talk about genetics. We've got a lot of stuff on the agenda tonight. And when I come back next time, I'm going to have the proper agenda up in front of me. My goodness, what a day. So I want to talk a little bit about what HCM isn't, and I'm going to go through some of these slides kind of quickly because Omar is going to go over some of them as well in a different, with some different slides. So many of those patients who are watching tonight have been told for a period of time that they have something else that was being attributed to their symptoms that wasn't HCM. So athletically induced asthma, panic attacks, innocent heart murmur, panic, depression, mitral valve prolapse, family history of wonky hearts, or you name it. We've heard it all at the HCMA. But the reality is hypertrophic cardiomyopathy is at the root of the symptoms that you're feeling that were previously called something else. The one that probably has been the most significant over the years are innocent murmur and athletically induced asthma. But we have new technology today that's going to assist us in making sure that we identify the undiagnosed, and that is through the help of technology such as electronic medical records. And there are a number of efforts underway around the country to use electronic medical records to help identify those who have many facets of what might be considered HCM to get them to a more prompt diagnosis. So I'm going to talk very briefly, because this is going to get talked about later, about the prevalence of HCM. And many of you may have heard that HCM is 1 in 500 in the general population. And that's probably not true. It's probably more than that. However, the majority of people who have HCM and have symptoms are probably in that 1 in 500, but there are additional ones that could get identified. And that would be through MRI and genetics. And we know that multiple family members can be affected. And that means you find one family, you tend to find more within that little pot of a family. So in the United States today, we know that there are between 750,000 and 1 million Americans who have diagnosable HCM, either by genetics or by imaging. But right now, only about 120,000 of them are actually in clinical care for HCM, like many of you watching this evening. So that's a problem, and we need to find the rest of these people before something bad happens to them. So we're going to be talking, I'm going to be talking a little bit more later about some initiatives that we're putting forward in the next couple of months that you can get involved with to help us raise awareness. So we do think that HCM is the 1 in 200 number now, not the 1 in 500 number now. So I'm going to just populate this whole slide out here. We're going to talk a lot about genetics tonight. We're going to talk a lot about this whole concept of what the cardiac sarcomere is. And what I want to make sure that we understand is, if you're joining us tonight and if you have been told you have HCM, it's critically important to use all of the technology we have today to make sure that you have sarcomeric HCM or unknown gene mutation HCM. I have to turn this freaking phone off. Sorry. It's going nuts tonight. So we want to make sure you don't have one of the mimickers of HCM or the phenocopies, such as PRK, LAMP2, Fabry's disease, or even amyloidosis or sarcoidosis, because they have very different treatment pathways, as do some of the syndromes, Noonan syndrome, Leopard syndrome, Costello syndrome. So we want to make sure that you're getting the proper diagnosis, and we know that that happens best in an HCM Center of Excellence. This is a pathway of disease that you might follow with HCM. You may be asymptomatic or just gene positive or viewed at low risk. That doesn't mean you can just check out and not pay attention anymore, because things can change over time, but they need to be followed up over life. You could have a high risk of sudden death. You could have a high risk of progressive heart failure with obstruction, or advanced heart failure without obstruction, or atrial fibrillation or stroke. So there's all these different pathways. And why is it critically important to understand what your pathway is and what your treatment options are, and getting a proper physician involved in your care who understands HCM at a very high level? It's because of this. We know that the average cardiologist in America sees about 2,000 patients in their practice. And that means the average physician is seeing about 10 patients with HCM. Now, the tricky part is, where does the patient fall? There's 5 basic pathways. There's more than that, but these are the major pathways that somebody with HCM could follow. And if your doctor only sees 10 patients with HCM, what are the chances they have any depth of knowledge or understanding of any one of these individual buckets? So that's why we believe in the high volume center of excellence model. So we created not only the model, but we created a logo too, because we thought that would be fun. So right now in the United States, we have 41 centers of excellence, and 2 of them are located in Utah. And interestingly, they're quite close together, but there's a reason for that. Why would one smaller community, well, it's not exactly a small community, but why would a city like Salt Lake need 2? Well, there's different insurance access points, and there's different expertise in each center. So I think it's critically important for people to know that not only do they have a center in town, they have lots of options. So that's really critical. I will tell you, at this point, we have 8 applications pending for new centers. I actually spoke to another one today. So we have some new centers coming up over the next year or so. It's a little difficult to do site visits during COVID, so we're doing our first virtual site visit in a couple of weeks. We hope that works well. And we are going to be adding to our Center of Excellence model in the coming year with a new mentorship program for programs that are smaller and don't have the depth or breadth of knowledge that the larger programs have. We think it's critically important to ensure that all patients in the country have access to high quality care and have that expertise available to them. So in the beginning of some of these newer programs that may come on in the next year or so, you may hear a term that's new. It's called an HCMA mentored program. So that means they'll be under mentorship for a period of approximately a year, which means if you're going there for care, that physician will have access to not only 1, but up to 4 experts that will be available to them to consult on a bi-monthly basis on complicated case management, and they'll be learning from the thought leaders in the field. So we're really excited to get that program up and running. It's going to take a couple more months to get everything worked out there, but I think it's going to be really great. Okay, so what is an HCMA recognized center of excellence? As Dr. Pinson earlier mentioned, we have a HCMologist, and yes, we thank Harry Lover for that terminology because he's the one who created it. So a HCMologist is the gatekeeper for HCM. They're the one that takes all the pieces of the puzzle and puts them together and makes sure that the right experts are brought into the equation. And that means when you come into a center, you're going to go through a pathway with your Center of Excellence director, and you may land in buckets outside of his office or her office, as the case may be. And you might go over to advanced heart failure for an evaluation for maybe transplant pathway. And they may say, no, you're not ready for us yet. Go back to the Center of Excellence. You may need a visit to maternal fetal medicine, as Holly recently had, as evidenced by that beautiful baby that was here earlier. You might need to go over to genetics for a while and meet with Ivana. You may need a mental health professional, an interventional cardiologist, or a surgeon like Dr. Saltzman here. But then it is critically important that you come back to your Center of Excellence director and you are treated there, because each of these other pathways, you might have surgery, you might get rid of your obstruction, you still have HCM. You may need a defibrillator, you still have HCM. You might have atrial fibrillation. We have to take care of the atria, but then we also have to take care of the ventricle. So we need to have all of these people in concert with each other with a director. Think of them as the conductor of the orchestra, if you will. So you're going to see this terminology pop up more and more. The new guidelines are coming out for HCM. They should, I thought they were going to come out this weekend, but I don't think they're coming out until the end of the month, possibly the beginning of next month. So they're going to be talking about comprehensive HCM center of excellence model, primary HCM centers, and the role of your primary cardiologist. And as represented by the stars on this table, the Center of Excellence obviously is 5-star all the way across the board. That's where you're going to get the highest level of expertise in any of the areas related to HCM. But there's some smaller centers where you can probably get some good imaging done and good family assessments done, but you probably don't want to have surgery there, and you probably don't want to deal with really complicated arrhythmias there. You want to go to the highest level possible. And your primary cardiologist certainly plays a role, because if you're in your community and you, I don't know, pass out at your desk one day, you might not be able to get to a center of excellence very quickly. You might have to go to your local emergency room, and it's critical that your local doctors know who you are. So that's the whole comprehensive care model. So what do we know about patients who were treated in a center of excellence model? And we've surveyed them over the years, and we found out that they have both better physical and emotional quality of life. Their outcomes from invasive procedures have lower complication rates when compared to receiving care in a high volume or low volume center. So it's better to have high volume. And they have the ability to participate in clinical trials and research, which enhances our ability to understand more about HCM. And it also gives them an understanding of how they can get involved in a deeper way. So we've proven definitively that surgical outcomes are better in high volume centers. There was a paper published about 3 years ago, maybe 4 years ago now, that if you had your surgery done in a low volume center, 1 in 8 ended in disaster. If you have your surgery done in a high volume center, over 90, I think it was 98.9% had very good outcomes. We also know that patients who are treated outside of a center of excellence are much more likely to be put on inappropriate medication or have more invasive procedures done to assess their status that might not necessarily be necessary. And we know that they're going to get care that is consistent with the standard of care and the highest level of outcomes. Hello, Jared has joined the group. So one of the programs that we have at the HCMA is our social media presence. And if you told me many years ago that Facebook was going to be this amazing resource for our patient population to communicate, I don't know if I would have believed you, but as of today, we have nearly 12,000 engaged with our main page. And then we have some groups. The parent network, communication network, is being built up right now. It's a newer page for us. But our official HCM discussion group, which is this one over here, it's called Hypertrophic Cardiomyopathy, HCM, HCMA, and that private group can be found from our Facebook group. We have probably like 6,000 people in that group with trained moderators who are monitoring every post every day, multiple times a day through several different time zones, including members that are in Europe, members that are in Canada, and all over the United States. So it's pretty odd that you can go more than an hour without somebody having researched or written back on your post. We are building out HCMAI, which is going to be an international grouping. So we're going to build international mini HCMAs out there so that we can help patients in their native language. We have just, it's not out yet, but late breaking news, we have our Swedish language poster available. And we are working on Dutch and Spanish right now. So we're working on those. And we also have somebody out of Portugal who is going to be working on a program as well. And we're hoping to hit South America soon. So we have these new programs that are coming up, and each of our affiliate groups, likely, we're not sure if that's going to be the definition of them or not. They will be anchored to the HCMA Facebook group. So they are part of us. They will use our materials and we'll just help them translate it into their language. And we will build a network of HCM's experts in each country. So right now we're building up Sweden, which my grandfather would be very proud of because he was a Swede. So I don't know why we ended up starting there, but that's where we're starting. Okay, so coming very, very soon, hopefully in December, you're going to start seeing these populated out. We are going to be holding online support groups, eventually in person again, but not till COVID goes away. Our groups will be limited to about 25 participants per group. They're going to be kind of set up, I want you to think of it as radio shows. Each support group leader has their own personality and their own way of addressing things. We have 2 former police officers that are going to be running groups. We have somebody who likes to do a lot of journaling and writing and kind of metaphysical kind of thinking. We have some kindergarten teachers, and we have all different kinds of wonderful people who are going to be running these rooms. And we're going to have agendas, and we're going to invite speakers such as, I don't know, some of the people in this group tonight might be getting a little letter saying, hey, would you like to join us for a support group? And they'll do an educational presentation, and then there'll be discussion. So they're going to have different formats on different nights in different places. But the goal here is that anybody seeking support shouldn't be more than 48 hours away from a support group meeting being available to them from the comfort of their own couch. And we know even if it's not COVID times, most people with HCM are not interested in going out to a meeting after work and then having to drive home. They're too exhausted. So this way you pop up your laptop and you're sitting on your couch and your big-hearted friends are going to be right there to join you. Coming next year, we're going to build out the peer-to-peer Big-Hearted Friends Network. Think of it as the eHarmony of HCM peer support. You'll do a survey, they'll do a survey. We'll try to match people up based upon what's important to them and what they're experiencing at that point. You may find yourself being a mentor peer, or maybe you need some guidance from somebody else, or maybe you're going to find somebody who's going through a lot of the same things and you're going to just support each other. The relationship may last a day, a week, a month, a year, a lifetime. It's up to you on what that does. We will just be monitoring from the back in case there's any problems or bumps in the road. So that should be coming out first quarter-ish next year. We've got a couple of projects we're working on right now, but this is next up on the hopper. Hopefully many of you have already signed up to the Share Your Story program. We're going to be building out our brand new website. It's going to be very exciting, very interactive. You will have the opportunity to go to a page on a particular topic, let's say ICD. You know you're going to be needing one soon. You're a little scared about it. Our website will have not only some clinical understanding about what an ICD is, who needs one and why, but there'll be 3 video boxes on that page. Video box 1 will be the patient perspective, telling you I've had an ICD, this is my experience. There'll be quick 2-3 minute little videos. We'll have medical experts explaining what the ICDs are, what the procedures are, and getting into that type of detail. And then you'll be hearing probably from yours truly on the HCMA perspective on where we think best care is for that particular issue, or things you need to think about, things you need to pack, things you need to plan your life around because of that particular topic. So we'll do it with myectomy, atrial fibrillation, ICDs, And we'll also do the diagnostics. What is a VO2 max stress test? What is a stress echo? What is a cardiac catheterization? When are they really needed in HCM? What is, a radio frequency ablation? What is a cryoablation? We're going to help answer all these really complicated questions, and they'll all be sourced and cited, and it's a big project. So the share your story part of it is going to be people just like you showing up on your computer at 3 o'clock in the morning when you're freaked out, so you can find some support right then and there. They're also going to be, some of them are going to be sharing their stories on the podcast, Tales from the Heart, which we do 2 live broadcasts monthly with Drs. Marin and Dr. Lever. And I bring in other interesting individuals from time to time to have different discussions. And that program will grow in 2021, and we'll be doing more programming there, as well as just sharing groups of patient stories and patient discussions. So that's going to be fun. We have the Elizabeth T. McNamee Legislative Subcommittee, which just celebrated its first year, and we are going to be kicking off with our training for our legislative advocates coming up. We're going to be focusing originally on state level legislation to improve the well child examinations and ensure that they include cardiac components. Believe it or not, the state of New Jersey currently is the only state that asks cardiac questions in a well child exam. So we're going to take the model that we've built here in New Jersey, and we're going to hopefully plant it all over the country so that every time a family goes to the pediatrician for a well child exam, they're going to be asked cardiac questions about the child, which hopefully will spur mom and dad onto saying, hey, wait a minute, I have these symptoms. Maybe this is an opportunity for me to discuss it with a physician. We also want to improve student athlete screening processes and make sure that all of the professionals that are doing both the well child and the student athlete physicals are trained and know what the diseases are that they're actually looking for. In New Jersey, we created a state module that they get a little certificate when they complete, and they have to do it at certain intervals. And if they don't do it, they don't get reimbursed. So it's great to have legislative teeth there so that there's a benefit if they do take the course and they learn a little bit. So we will be building up that. We're also going to be supporting AED CPR legislation as well as Good Samaritan coverage. We all know that federally speaking, healthcare is a major issue, and we will be advocating on behalf of ensuring all those with pre-existing medical conditions maintain their health coverage. And I'm feeling a little bit more positive this week than the last session that we did, because the grumblings from the Supreme Court hearing on Tuesday seem to indicate that they weren't willing to disband the law in its entirety. We also are working with the FDA, the CDC, and other agencies to give input on matters of importance to the community, whether it be physician community, researcher community, or patient safety issues. That's what the legislative subcommittee is going to be working on. And if you want to be a volunteer, you can email us and Julie will get you involved in our training program. We're going to give you all of the work that we put together to validate our positions on what we want to have done. It's only a 245-page document at this point. Don't worry, you don't have to read it all, but we have all of the citations that you'll need to help explain to your state level legislature why this is an important concept to move forward. And where do we go? If you have not already taken the time to view our patient-focused drug development meeting, I would encourage you to do so today. You'll see these little boxes over here, and that is the patient perspective. We did about 10 videos like this where patients told their story. This will be included on the new website. So when they tell you the little bits of their story, then you'll be able to click on to the rest of the story and you'll hear a little bit more from certain people. Over time, we will grow out these sections. But for right now, I would strongly encourage you all to spend some time looking at the externally led patient-focused drug development meeting. This was our opportunity to tell the FDA what exactly it is to live with HCM, what the burden of disease is, and what we need from drug manufacturers, from the FDA, from regulators, to make sure that we have a better future and that we have more options available to us, and that they design clinical trials that are smart, that meet endpoints that are meaningful to those with HCM, not just a biomarker. So Elmer's going to be talking a little bit more about that. So I'm going to leave it there with a little fun announcement. If you are currently a member of the HCMA, That means a paid member. You have the opportunity to claim your prize. We have been given a gift of 1,000 23andMe ancestry kits. There is no connection to HCM on these 23andMe kits. They're kind of fun genetics, if you will. And if you are a member, or if you would become a member, you can just put in the request. You go to the store, put the kit in the box. It's a zero priced item. There is an opportunity to make a donation if you would like to. And then we would process that and send you a link to the 23andMe kit, which is yours free of charge. And then that is between you and 23andMe. So I want to thank Myocardia for the in-kind gift of that 23andMe package. And as well, I want to thank our partners at the University of Utah, our other HCM centers of excellence, our staff, the board of the HCMA, our volunteers, and of course, Brandy, my donor, for without her, I would not be with you today. So I'm going to end it there, and I look forward to any questions at the end of the night. Okay, so we have chat questions here. Some people can't get in. Okay. So we're having some people with problems getting in. What I would suggest that they do, Omar, if you know somebody who's having a hard time getting in, they can email support@4hcm.org, and Julie will make sure that they have the currents. I have a hand up here for a question, and I don't know why I can't see who's asking me the question. Oh, because I'm at the bottom. Who's raising their hand? The hand went down. They didn't mean to raise their hand. Okay, the hand is down. So let's take a look at the poll before we get on to our next talk. So I'm going to end polling, and we had about half of you do the poll. We have representation from the Northeast, the Southeast, the Southwest, the Midwest, with the most populated being the West, which is good because you guys are in the West. We have somebody from Europe, Australia, and an other. I'm not quite sure where other is. Other can tell me in chat where other is from. We have 58% are patients, 8% are family members and a patient, 4% are family members, 4% are a friend, 21% are healthcare providers. That's a large number for us. One is just curious. That's interesting. I don't think we've had a just curious yet. Welcome, just curious. We like just curious. So of the population that's here, I'm sorry, I thought I was sharing my results and you were reading along with me. We have 17% are diagnosed in the last 2 years. So welcome newbies, we'll get you through this. 38% are on meds, 25% have ICDs, 21% have had septal reduction therapy, 29% have experienced atrial fibrillation, 13% of us have lost a family member, 63% have had genetic testing. That might be a highest number we've seen yet there, so yay. We have a few people who have both been advised to get an ICD but haven't done it yet, and septal reduction and haven't done it yet. So we have people making decisions tonight. So no stress on there. Okay. So hopefully we'll answer all their questions tonight. So because I screwed up and I put the wrong Utah agenda up front, I'm guessing, Omar, you're going next, correct?
I'm going next.
You're going next. Okay. So without further ado, I am going to hand it over to you and you can share your screen, and then I'm going to mute and black my screen so everybody pays attention to you.
Thank you, Lisa. Let me try to figure this out. Okay, well, Lisa, the work that you do is just amazing. It seems to me that we're gonna need to either clone you or request an extension of the hours in your day.
Well, Ivana is the genetic one. Maybe she can work on something, because it would be nice if somebody else would do the work and I could go have some fun.
Hey, can you see my slides now?
We can now. Thank you very much.
You can, great.
It's all yours.
All right, let's talk about medicine business now. Okay, so today we're gonna talk about how we evaluate and manage patients with HCM. I have no financial disclosures, no relationship with the industry. I do have a grant from the NIH, which is really not related to HCM. This is the outline of what I will be discussing today. We're gonna define the problem. We're gonna talk about the pathophysiology, how you guys get all the symptoms that you experience on a daily basis. How we risk stratify patients for the occurrence of sudden cardiac death, and therapeutic strategies that we have. And I'm gonna focus on medical therapy. Dr. Craig Salzman will talk about another options that we call septal reductive therapies. So let's start by defining the problem. So HCM, what is the definition of HCM? Lisa talked a little bit about this. It's LV hypertrophy, which is not explained by loading conditions, right? Those patients that have a valvular problem, aortic stenosis, hypertension, which makes the heart work harder, definitely those patients do not qualify for HCM. So how we diagnose hypertrophic cardiomyopathy? We diagnose this with the use of cardiac imaging. For the longest time, echocardiography has been the cornerstone of the diagnosis, but nowadays, cardiac MRI, it's gaining momentum. So what is the diagnostic criteria? In adults, we use a left ventricular wall thickness of 15 millimeters. If you have relative with a condition with HCM, or you have a positive genetic testing, we consider even 13 millimeters or more to be diagnostic for HCM. Lisa, talk to you a little bit about the prevalence, right? Based on older study, the cardiac study, the prevalence was 1 in 500, but we know now with the use of advanced imaging techniques, echo contrast, cardiac MRI, and now even genetic testing, that prevalence has been revised to 1 in 200. What is the cause of my condition? I have patients that they come and they ask, why do I have this? And family members asking, well, you brought this on yourself because of your bad lifestyle habits and all this. This is not the case. This is a genetic condition. And we know that the gene mutations, over 2,000 mutations have been identified in the cardiac sarcomere. The sarcomere is the contractile unit of the heart. And I'm not gonna go too in depth in this because Ivana is gonna talk to you about this. But what is the consequences of these mutations? And here I want you to pay attention to this. This is a sarcomere, and this is calcium molecules binding to the thin filaments, changing the configuration of that thin filament and allowing the thick filament, the myosin, to bind the head of the myosin to bind and lead to the contraction. In a healthy heart, this is gonna lead to a normal contractility and effective relaxation. Right? And you see that not all the head of the myosin are engaged, right? Unfortunately, in HCM, you can see that these mutations, they lead to increased affinity of those thin and thick filaments. So you see right there that those cross bridges are increased. This leads to hypercontractility, right? But at the same time, to produce relaxation, the calcium has to leave the cell, and all these cross bridges, they have to normalize. So go back to the relaxed state, which is from the energetic point of view, is more convenient for the cell, right? But in HCM, we have that all these cross bridges are always engaged, always consuming energy, right? This is gonna lead to energy depletion. So this is a very inefficient way of contract, right? We know that this leads to nuclear signals at HCM, which is gonna cause cell growth, leading to hypertrophy, and cell death, which is gonna lead to fibrosis. Why this is important? All the medications that we use nowadays, they really don't target this, but you can imagine that if we have medications targeting the main problem here, we could even find a medication that down the road is gonna lead to avoid progression of HCM and even avoid expression of the phenotype in patients taking this medication. So I don't have proof of this. This is just a dream, but it's good to dream sometimes. So once this happens, as I said, at the level of the tissue, you see that there's LV hypertrophy or hypertrophy of the myocytes, and you see the nuclei that are definitely bigger, and there's also disarray. This also leads to fibrosis that you can see with the blue stain there, and at the level of the tissue, there is hypertrophy. This is the typical asymmetric septal hypertrophy or ASH, or patients can have also a more diffuse type of hypertrophy. Now, with advances in imaging, and these are cardiac MRIs from our patients, we can identify that not only this typical phenotypes are occurring in the community. We can see here, you can see a patient with that Asse, that asymmetric septal hypertrophy, which is the typical, you see the typical concentric hypertrophy, but you can also see patients that have localized hypertrophy in different regions. For instance, in this patient, you can see this segment of the heart is called the inferior septum, and you can see that the rest of the ventricle looks fine and how it looks really thick in there. Other patients can have what we call apical HCM, right? So a lot of heterogeneity in this population. Now, to make things even more complicated, and probably you have heard about these patients that have the same gene mutation. They can be siblings, and sibling 1 presents with a certain phenotype, and sibling 2 presents with a totally different phenotype. So this is a very heterogeneous, very complex disease. To make things even worse, we know that the sarcomeric mutations, they can explain the LVH or that hypertrophy, right? But there are different findings that are really not explained by these sarcomeric mutations, right? We talk about this, why some regions get thick and others they don't, right? Why patients develop apical aneurysms, why some patients have elongated mitral valves, why patients with HCM have abnormalities of the small vessels or arteriopathy, right? They have this thickening of the intima and the media in these patients that lead to lack of blood flow in those regions and what we call ischemia, right? Why the patients develop fibrosis and why patients have abnormalities of the papillary muscle, right? This is not fully explained by this monogenic hypothesis. And there's some thought that in patients with the background of the main gene mutation, the coexistence of other mutations can lead to this. There's another other hypothesis that also talk about that the environmental factors can lead to a change in these or all these different expressions in the disease. So very complicated. And so from the clinical perspective, Lisa already talked a little bit about this. Some patients will do very well. Some patients, unfortunately, will experience heart failure symptoms. Some patients will experience atrial fibrillation, about 20% of the patients, and Jared will touch on this. And unfortunately, some patients, smaller group of patients, about 0.7 to 1% of the patients will experience sudden cardiac death. Right, from as a patient, what are the common symptoms that patients with HCM experience? Lisa, again, touched on this, shortness of breath, chest pain, lightheadedness. Some patients can even faint, right? Palpitations. Some patients or provider may think that the patient has even anxiety, as Lisa mentioned, fatigue, and fluid retention, which is manifested either as a swelling in the legs or abdominal bloating. Now, why is this crown there? This crown is there because, unfortunately, the research has shown that women, unfortunately, they can have more severe symptoms than men. And this may be related to a smaller heart. And we talk about the pathophysiology so you can understand this a little bit better. All right. So let's talk about why you guys develop symptoms. What is the pathophysiology of this? So when we talk about the pathophysiology, it's really important to establish if the patient has obstruction or no obstruction. So what do I mean by obstruction? In the healthy heart, like you can see here, the oxygenated blood comes from the lungs to the left atrium, and from the left atrium, it goes down to the left ventricle, which is the main pumping chamber. From the left ventricle, the blood leaves the heart through the aorta to be distributed to the organs, right? And when it leaves the heart through this outflow here, or that outlet here, that we call the LVOT, or left ventricular outflow tract. And some patients, in fact, 2/3 of the patients with HCM will present some degree of obstruction, either at rest or with provocation, right? And we call that obstructive HCM. And you can see here in this patient, the SAM, or what we call systolic anterior motion of the mitral valve, of the obstruction when the heart is trying to eject. And in this clip here, you can see there's a lot of turbulent flow, which again is is turbulent because there's an impediment to the ejection at that point. In this patient has clearly no obstruction. This is one of our patients, no obstruction there. And again, you see that there's more laminar flow and no obstruction. So let's talk about the factors that lead to obstruction in patients with HCM. So we talk about the healthy heart. You know, the heart ejects and all the blood gets through the outflow tract and the aorta without any obstruction, no problems, right? So, but in patients with HCM, that doesn't happen. And some of the factors, some of the substrate that leads to this is one, hypercontractility. That's a functional substrate, and we know why. This is related to the gene mutations, right? The other factor is that septal hypertrophy. That septum physically obstructs the LVOT, but not only does that, it also redirects the blood flow through the posterior aspect of the mitral valve, and that kind of pushes and drags the valve towards the left ventricular outflow tract, right? Another problem is that patients with this condition, as I mentioned already, they have abnormal mitral valves sometimes. You see that elongated, especially the anterior leaflet of the mitral valve. You see how is that very elongated compared with that normal valve, right? Some patients will have anomalous papillary muscles. Those papillary muscles are in charge of, sustaining that valve, sustaining the leaflets of that valve. And those papillary muscles are located anteriorly, which leads that coaptation point to be displaced anteriorly. And so it's easier to get into the left ventricular outflow tract. So a lot of factors that lead to this. Now, from your point of view as a patient, there are activities also that don't lead to obstruction, but they can contribute to obstruction, right? And this is really important for you to know, right? You can look at these cartoons and you can think, it's very easy, common sense. If the cavity chamber here, you have that cavity of the left ventricle is smaller, everything's just gonna be crowded in there, right? So it's easier for you to have obstruction. If the cavity size here is bigger, you're gonna have less obstruction, okay? So what are the activities of the daily living that patients with HCM can worsen obstruction in patients with HCM? Hypovolemia, right? If you are dehydrated, you have diarrhea or you're not eating and drinking well, right? You're gonna have low volume status, the cavity size is gonna be smaller, you're gonna have more obstruction, right? Increasing the heart rate, exercise. Why is that? Because when you're exercising, the heart is just beating faster, and this doesn't allow the heart to fill with blood and make that cavity size bigger, right? Valsalva maneuver. This is what we ask you guys to do every time that you see me in clinic, but it can happen also when moms are gonna have a baby, right? When they have to bear down for a reason. Why this happens? Because when you increase your intrathoracic pressure, right, there's less blood flow going from the lower part of the body back to the heart. And if there's less blood flow going back to the heart, there's more obstruction, right? Alcohol and large meals, they cause a lot of blood pooling in the intestines, right? So if there's more blood pooling in the intestine, there's less blood going back to the heart, there's more obstruction, right? So all those are factors. And I have heard from patients that when they go to Chinese buffet, they feel terrible. They drink wine, they feel terrible. So just few examples. Now, this is a patient of ours that, and this is case just is mainly to highlight the importance of the mitral valve, right? And you can see here, as I showed you in the previous clips, this patient has obstruction. You can see that valve getting in there. But something that's really striking that this patient is really not super thick. So there's not a lot of hypertrophy there, right? So the main mechanism here is an elongated valve and a papillary muscle is anteriorly displaced. So if you don't recognize that, and you send this patient for myectomy and you think that doing myectomy is going to address the problem, unfortunately, you're not going to have a good outcome, right? And this patient at baseline had a gradient of 200 millimeters of mercury. Just to give you an idea, normal is around 5 and 10. And obstruction, we call anything more than 30, right? So this is a very severe gradient. And this patient was very symptomatic, right? Luckily, and this is one of the reasons that we have the centers of excellence, we have discussions with our surgeon and we planify this, and the patient had not only myectomy, but she also had mitral valve repair, and you can clearly see that there's no obstruction. This is a surgery that was performed by Craig Salzman, right? And at the end of the day, the patient, again, minimal gradient, very good results. So what are the negative consequences of having this obstruction at the level of the LVOT? Now, obstruction is going to increase the left ventricular systolic pressure. It's going to make that left ventricle work more, right? Decrease relaxation. And because of that, the heart cannot fill with blood. If the heart doesn't fill with blood, the liters per minute that the heart is able to pump is reduced. And that leads to symptoms of fatigue. That also can lead to symptoms of ischemia, angina, right? Mitral regurgitation, which happens related to the obstruction and that valve being dragged anteriorly, right, is going to lead to pulmonary hypertension. It's going to lead to symptoms as well. What about in the long term? What are the consequences of this obstruction? We know that obstruction leads to increased mortality, whether it's related to HCM related death or sudden cardiac death. We know that having obstruction, you can see here, these are survival curves. Patients that have obstruction, the survival is lower compared with those patients that have no obstruction, right? And they have significant symptoms compared with those patients without obstruction. Now, what is the effect of relieving that obstruction? And this is a study where patients that had myectomy and alcohol septal ablations were included, and you can see that the survival improves and is very comparable to those patients that have no obstruction. Unfortunately, some patients will continue to have symptoms, and this is probably related to incomplete myectomy in those patients or incomplete relief of the gradient by alcohol septal ablation, which happens. Okay, so let's talk a little bit about the patients with a non-obstructive HCM. And this is the group highlighted here. The patients with non-obstructive HCM, luckily they're gonna have none or very mild symptoms, 90% of them. And you can compare to the patients with obstruction, right, which is clearly less. 10% of the patients though, they're gonna have significant symptoms, what we call NYHA class 3 or 4, right? And those patients, unfortunately, are gonna have higher mortality, higher rates of going towards heart transplantation, and having more sudden cardiac death events. And this is a study by one of my co-fellows many moons ago, AJ Shah, where he tried to characterize those patients that have non-obstructive HCM. And he found in his study, the prevalence was a little bit lower, it was about 5%. Half of those patients, they have severe symptoms. So what are the characteristics of those patients that were severely symptomatic and they have increased mortality? Those patients have mid-HCM. So those are patients that have diffuse HCM. You can see that the heart cavity, which is black here, is just very minimal. You know, it's a pump that doesn't really have room to get blood inside. So they don't have that amount of liter per minute that the heart can produce, right? Those patients also have mid-apical HCM. You can see these are images with contrast now, where the blood pool now looks bright here. And you can see the thickening of the heart muscle here at this level. And some of those patients will create that outpatching of the apex that we call a left ventricular apical aneurysm, that we know that is associated with cardiac arrhythmias and also clot formation and thromboembolic events. So awarding patients with apical HCM, these are patients with, from our program again, you see the thickening is really mainly in the apical aspects. This patient has small cavity, these patients can have a lot of fatigue, and you can see that this patient really has, that heart is really not able to fill. And you look at the size of, this is the left atrium, this is the top chambers, which usually should be very small. These are actually bigger than the actual ventricle. So this is a patient that is really struggling from the diastolic dysfunction and high filling pressures point of view, right? This is another patient with apical HCM, and this is one of the problems. You see here, all this is what we call delayed gadolinium enhancement, and this represents essentially scar tissue. This is myocardium that is infarcted, you know, and the reason being, this apex has been trying for a long time to get the blood out, but because there's mid-apical thickening there, that doesn't allow the blood to get out, and there's increasing pressures at the level of this cavity and causes fibrosis, right? The heart muscle dies, right? And this is what leads to cardiac arrhythmias. And we know that this group, particularly, they have an incidence of sudden cardiac death between 3 and 5%, which is really high. I show you the incidence in the general population. So diastolic dysfunction is another problem. I told you why, from the functional perspective. You know, the mutations, they decrease the super relaxed state of those cross bridges. So the heart is always engaged and consuming energy. This is one of our patients, and she's probably listening to our talk today. This is a patient that has a lot of diastolic dysfunction. You can see those big atria. She had a lot of symptoms, and some of these symptoms because the heart, and you can look at it and you think, well, this patient doesn't have HCM. And it is true, it looks relatively thin. There's very mild hypertrophy there when we measure about 1.3, 1.4, so barely meeting criteria, but she has positive genetic testing, right? And she has high filling pressures in right heart cath. She has left atrial enlargement. And again, this is even in the absence of that marked left ventricular hypertrophy. Now, when you develop left ventricular hypertrophy on top, you're going to have also worse diastolic dysfunction, which is going to lead to symptoms. Other sorts of problems, myocardial ischemia. I talked to you about the problem with the at the microvascular level. Now you have a supply-demand mismatch. Now you have to feed that thick heart muscle, right? Patients with HCM are just regular human beings, so they can have normal coronary artery disease as shown in this CAT scan, where you can see all the cholesterol plaque in here. The obstruction also leads to ischemia. Okay, so let's talk a little bit about the risk assessment for sudden cardiac death in HCM. The contemporary definition of HCM is a sudden death in young asymptomatic individual. You know, and in fact, in the United States, HCM is the leading cause of death in young athletes, right? The main mechanism is ventricular arrhythmias, VTVF. Other rhythms can occur as well, but VTVF is the main cause. The incidence is 0.71% in non-referred patients. We talk about patients with apical HCM having between 3 and 5%, right? And that's why, and we know also that defibrillators, those are the special devices that are used to protect patients from sudden cardiac death, they're effective. They're effective. So based on this, our cardiovascular guidelines recommend that all the patients should undergo comprehensive screening, restratification for sudden cardiac death. And whoever needs an ICD should get it. And this is what we use. These are the criteria that we use to establish who's at the higher risk. And we use this is what we call the American system, right? Where there's established risk factors involve family history of sudden cardiac death, unexplained syncope, right? If you're, you know, in a line, you know, waiting for the last CD of Van Halen or Michael Jackson, that doesn't count, right? It has to be unexplained. LV thickness of 3 centimeters or 30 millimeters or more. No sustained ventricular tachycardia and Holter monitor, and that's why we every other year we monitor the heart rate in our patients with a Holter monitor. Abnormal blood pressure response to exercise. So how much is it's a high risk factor? So this study addressed that question, right? These are patients that receive an ICD and patients, and we quantify and we stratify the patients based on risk factors, whether they have 1, 2, 3 risk factors. And we also look at the incidence of shocks that the patient had. And you can see whether you had 1, 2, or 3 risk factors, really the incidence of those shocks is about the same. So based on that, our societies recommend that ICD should be considered in patients with 1 or more risk factors. Now we do have what we call modifiers, and I want to highlight 3 of them. Which is the percent of fibrosis or percent late gadolinium enhancement, which is the same that we quantify in MRI. The presence of that apical aneurysm, I told you why. And burned out HCM, which is essentially a patient that has, now the heart has gotten weaker over time, right? And this is a different set of problems. So I want to highlight, this is a study that led to the clinical use of the cardiac MRI and fibrosis quantification. This is a study that involved over 1,000 patients. And again, fibrosis was quantified in all of them, and the patients were followed for sudden cardiac death events. And you can see that the freedom from sudden cardiac death events decreases with increasing amount of fibrosis. And based in this study, we determined a threshold of 15% of the total LV mass. If you have more than that in terms of fibrosis, you have a significant risk that will justify a defibrillator implantation. And this increases your risk by 2-fold for sudden cardiac death. And this is an example of a couple of our patients. And you can see here in this cardiac MRI, the myocardium looks nice and black and beautiful, very homogeneous there. He has no fibrosis, right? In this patient though, we have a lot of fibrosis. You see all these white patches, this is all scar tissue. Right? And this is essentially the islands of tissue that work as a short circuit and are gonna lead to those ventricular arrhythmias. He has a lot of fibrosis, 42%. He was sent for a defibrillator, and so far these 2 patients are doing very well. Okay. There has been more recently a push to use what we call the enhanced American system to restratify patients, which is essentially all the 5 risk factors that we discussed already, in addition to that percent fibrosis, including that LV apical aneurysm, and also looking at drop in EF, which is that burned out HCM group, right? So in this study, patients with HCM, they were stratified whether they have these factors, and patients were followed for sudden cardiac death events. And what you can see here in this graph is that this scoring system essentially stratified the patients very well. These are patients that experience ICD shocks, right? For the large part, and they all have at least one risk factors. And you can see that these patients were properly assigned to receive an ICD, right? Based on one of these factors. So very good. Now, we have patients here that they experience sudden cardiac death, right? So we missed some, but why do we miss some of those patients? And this group is only 5 patients. We missed some of those patients. One was an apical aneurysm that it was not diagnosed at the time. The imaging probably wasn't advanced at that time as it is now, and that patient, that apical aneurysm was missed. So the other one, the patients were actually identified, and they were recommended, they were advised to get an ICD. They wouldn't do it. Like the two patients that we have here in our group, right? They're thinking about an ICD or not, should they get it or not, right? You see, resuscitated cardiac arrest in patients without ICD. So these patients dropped dead. They dropped dead, but they were safe, right? 7 patients. Now, most of those patients, 5 patients, they declined the ICD. They decline. And this is really important. This is really important because some of my patients, and I have about 2 patients, right, that we have recommended ICD, they don't want to do it. And the reason being is like, I don't feel sick, I feel okay. I'm young and invincible, right? So these are 2 sisters that were patients of ours. Now, unfortunately, they have moved out of state. And one of these sisters is Bethany, and this is Hannah, right? And Hannah, she had an ICD, thank God. And she suffered from an ICD shock, and she was saved by her ICD. She had actually 2 shocks, and you can actually watch her video in this YouTube, in her YouTube channel, right? But if it wasn't for an ICD, Hannah would not be here today. And at that time, Hannah was young, Hannah was invincible, right? So it is really important to consider this. And without this, we would not have Hannah here working on great stuff. They are like baby Lisas right now, working on their support groups and trying to encourage the use of defibrillators, creating their organization and supporting people. And you can see here the support that they're giving to the community, right? Patients know and they relate to Hannah and Bethany, and this is really helpful. Now, what is our role, the role of the University of Utah in Southern Cardiac Risk Assessment? This is research that we're conducting essentially. Patients, we're conducting what we call strain imaging, 2D and 3D strain imaging, where we look at the deformation of the myocardium, and we're trying to correlate that with ventricular arrhythmias and also with sudden cardiac death events. We don't have results of these studies at this point yet, but there's more to come. Okay, so let's talk about medical therapy, treatment options. So similarly, let's stratify the patients in obstructive and non-obstructive HCM, right? We have, if the patient has obstructive HCM, what we do, we treat with beta blockers, calcium channel blockers, verapamil, or disopyramide. Why we use these agents? Because we're trying to decrease the contractility of the heart to avoid that forceful contraction. We're trying to decrease the heart rate so the heart can relax, fill with blood, and trying to minimize the obstruction that way. So we always push to a higher doses of these medications until we get a heart rate between 50 and 60, right? While I'm very appreciative to the service that these medications have provided to my patients, these medications are really not specific, right? Now there are new kits coming, new kits on the block coming, right? And one of them, even though it's not FDA approved, I would like to discuss with you, which is mavacamten. Right, mavacamten it's a selective allosteric inhibitor of the cardiac myosin interaction. And as we discussed before, this is a normal sarcomere. This is a sarcomere with HCM. And you can see after the introduction of mavacamten, you see all those cross bridges are kind of normalized, which attenuates the contractility of the heart that helps with obstruction. Also, there's improved relaxation and improved energetics. And this is the Pioneer HCM trial, which is a phase 2 trial to assess the role of mavacamten in patients with obstructive HCM. Patients in this study were assigned to a low dose group or high dose group of mavacamten. The primary endpoint was a change in LVOT gradient at 12 weeks. And you can see here, this is the high group, right? And you have the LVOT gradient here. We have the LVEF, we have, and then we have either the amount of gradient again, if patient had resting or post-exercise obstruction. The first thing that we see is that the left ventricular ejection fraction, it did drop a little bit, but still within the normal range. And when we look at the level of obstruction, you see there's a marked improvement at the end of the study at 12 weeks, right? Compared with baseline, right? And this was a change of 90 millimeters of mercury, which is really impressive, right? With the low dose, we saw some improvement as well, but not as impressive with the high dose. The results of this study led to the phase 3 trial, which is Explorer HCM. The patients were randomized to placebo or mavacamten, right? The primary endpoint was an increase in peak VO2, which is a marker of functional capacity in patients of 1.5 or more, and an increase in NYHA class. That means that the patient had to improve symptomatically as well, feel better, right? Or if the patient had an increase of 3 in the peak VO2 without worsening in the NYHA class. And these are the results. We have in the mavacamten group, the primary endpoint was achieved in 37% of the patients, while in the placebo group, it happens only in 17% of the patients, which was significant. And you can see here all of the different components of that primary endpoint, and they were all significant. Again, very good results. Equally important, the ejection fraction remains stable. The obstruction, right, whether it was at rest, Valsalva, or with exercise, the obstruction in the mavacamten group, the blue group, right, decreased significantly in all those groups, right? So very good results. And this is the last stage of trial. So we were hoping to see this medication in the market, hopefully in the upcoming months. When we talk about quality of life, these are NYHA class. Again, if NYHA class is known to very mild symptoms, right? The patients in the mavacamten group, there were pretty much none, right? But over time with the treatment, there was more NYHA class 1 patients, so patients felt better. NYHA class 3 with patients with more symptoms, right? The number reduced. And they were not really significantly changed in patients in the placebo group, so patients felt better. Let's talk now about patients with no obstruction. Patients without obstruction, unfortunately, we don't have a lot of options. We use beta blocker to try to, again, improve filling time, calcium channel blockers, and diuretics. There are some surgical options, and Dr. Salzman will talk to you about those, but we're really limited in what we can do at this point. Now, mavacamten, as I said, it can also help to improve the relaxation of the heart. And this is a phase 2 study in which we participated as well. And it's called the Maverick HCM, where patients were randomized to a placebo control study, randomized to placebo or mavacamten, right? Patients with symptomatic HCM, normally EF, some evidence of congestion. Again, randomized and high dose or low dose based on plasma levels. We evaluated in this trial safety and efficacy. Efficacy was evaluated by NT-proBNP, which is a marker of wall tension, wall stress, the tension of the heart and congestion, right? And also troponin as a marker of wall stress related cardiac injury. And you can see, and this is the placebo, the dotted line here, that compared with that, the mavacamten groups, the high and the low dose groups, there was a significant decrease again in the NT-proBNP and the cardiac troponins. In terms of serious adverse events, 10% occur in the mavacamten group versus 21%. Right, so there was no really increment in the adverse events versus patients taking placebo. So in summary, HCM is a disorder with an heterogeneous genotype phenotypic expression. The pathophysiology of HCM, as you notice, is very complicated. Unfortunately, it can lead to symptoms that can be disabling, and it can lead to sudden cardiac death in a young population. Restratification of sudden cardiac death in HCM is important, and the enhanced ACCFIAHA strategy can be highly effective for risk assessment. The development, the future in HCM, it's really bright. The development of disease-specific therapies will be transformative for this field, as I mentioned before. And with that, I'd like to thank all the members of my team for all the hard work and all the support and for helping us to grow this program every day. Thank you.
Thank you very much. I'm going to switch your slides and I'm going to unshare you. And I am going to put up this slide real quickly. Wait, did it go? Did it go? Did not go. Hold on one sec. Oh, wrong slides. Let me stop share again and I will get that slide up properly. I don't know what it is about your agenda that is just kind of freaking the computer out today. There we go. And then we'll go like this. And oh my goodness, Lisa, what is happening here? And we'll go like that. And we're back here. Hello, everybody. Thank you for that excellent presentation and those cool graphics. And I'm really glad to hear that young lady had an ICD. I do want to make an announcement real quickly while I bring that up. There we go. There's the proper agenda for tonight. I knew what I was doing eventually. Sorry about that. There is a Q&A feature at the bottom of your navigation tool for the Zoom webinar, and you are free to use the Q&A at any time during the presentation. We will be addressing all questions at the end verbally. If there are silly questions you have that you're not wanting to ask at the end, or you want clarification on something, you can use the Q&A and our faculty can address those questions as we go through. So this is the proper agenda. I just wanted to make sure we got it up there. And next we're going to hear from Dr. Seltzman, who is going to talk to us about surgery and looking at the indications and challenges related to myectomy, which is a really important topic for this community. So I'm going to ask you to share your screen. And he's still dressed like a surgeon. He came straight from an OR, it looks like. I think Jared did too today.
I know it's really late in your hour now. Let's see, it's almost 9 o'clock. Omar did a nice filibuster in the typical way that medical doctors want to shut out the surgeons. He's now used the time of my time so that he could go right to Jared's talk, I see. But I'll try to get us back on, and I promise not to make any Van Halen references. Boy, that was a deep reference there. So my name is Craig Selzman. I'm one of the heart surgeons at the University of Utah, and Lisa, I just want to give my own shout out to you and your crew for all the awesome things that you guys are doing, and thanks for including us in this as a center of excellence. And we're really proud to carry that flag and hope we can live up to the expectations that you and your group and others put forward. So my task is to talk a little bit about surgery. It's not meant to scare anybody. Surgery is scary. When patients come into my clinic, nobody's there by volunteer. Nobody's voluntarily coming to a heart surgeon's clinic. And so we recognize that there's a lot of challenges. And I'm going to kind of blow through some slides because Omar nicely went over so many different things, and there are some overlap. But there are these different phenotypes or different types of HCM, and some of them are surgical based and some of them are not. And we're going to kind of go through that. Let's see, advance. Where's my advance thing? Oh, and ultimately the surgeon's role is when this really thick muscle gets in the way of the heart functioning well. And mostly the heart has to relax to let blood flow in. And we can't do a lot about that. The medicines can, but we sure can help when there's an obstruction. And the analogy I use in clinic is talking about a finger over a hose. And you can turn the water up at the spigot at the house as much as you want. In other words, make the heart beat as fast as you want. But if you have your finger over the hose, it's still not going to get out as well. And that has significant symptomatic implications for our patients. I don't know why I can't control this. is maybe here. Maybe this will work. There we go. So the pathophysiology is, as Dr. Weaver-Ponzon mentioned, you have this really thick muscle here. This is a cross section of the heart where the right ventricle is here and the left ventricle is here. The normal one is on the left side. And blood comes in from the atrium across the mitral valve into the main pumping chamber of the left ventricle, and then shoots it out the aortic valve to the rest of the body. And when that wall between the right ventricle and the left ventricle gets really thick, it can squeeze up against that valve, the mitral valve, and it doesn't allow blood flow to get out. And so that's fundamentally the pathophysiology that we need to address when we're thinking about surgical repair of this. Now, the history of this is really fascinating. It goes back many, many years ago, back into the 50s and 60s. And you might have heard someone talk about the Morrow procedure. And the Morrow procedure was generated at the National Institute of Health, where a lot of cardiac surgeons in the really the pioneering phases of heart surgery were all wrangled together. And this was basically cutting away some of that muscle that was necessary to avoid blood flow being obstructed. And then and over time, since the 60s, obviously, we've learned more and we've extended the procedure to address other issues as well. And so, as Dr. Weaver-Ponzon kind of alluded to, medical therapy is certainly the front line, but there are certain indications for surgery. And clearly, if you have this obstruction, this finger over the hose that causes symptoms, that is a class 1 or a very well supported indication for surgery. There are sometimes patients that have very high gradients. And remember, the concept of the finger over the hose. If your finger is over the hose, that's how you hit the bushes in the back of the backyard, because it's going to really spray out. And so if you have pressure that's really high on one side of the hose and lower on the other, when we measure the difference between those two, that creates this gradient. And theoretically, if you don't have your finger over the hose at all, the water just comes running out and there's no gradient whatsoever. But if you have some obstruction, you can see this difference in pressure. And that's what this LV outflow tract obstruction gradient is. And there's some patients that are that view themselves as asymptomatic with a high gradient. Now, a lot of times people don't know they're asymptomatic because this process takes years to develop. And sometimes you get used to these symptoms and you just, oh, I'm just a little bit more fatigued. Hey, I'm just getting older. That's a very common thing to say. And sometimes our patients don't know how bad they had it. And this is much like we see with other valvular diseases like mitral regurgitation, for example, that until you get something fixed, you don't realize that, geez, I've been feeling pretty bad over these last few years. So if you have a very high gradient, that's not normal. There's another group of patients that have a lower gradient, but in other words, the finger over the hose is not that tight. But when you do certain things, much like Dr. Weaver-Ponzon says, when you go into his clinic, he has you Valsalva or bear down. Those are what we call provocable forms, whereas if you do certain maneuvers, and this could be just walking up a flight of stairs, when you're sitting around on the couch, there's no real problem. But as soon as you start to walk and do a little bit of exercise, that heart becomes a little bit more contractile and it exacerbates the obstruction that's there. And so this is called latent LVOT obstruction. And finally, I am a good soldier, and whenever Omar tells me to do something, I do it. What does this look like from a cartoon standpoint? So back here is that first kind of picture that we showed. This is the right ventricle up here, the left ventricle here. This is the left atrium, the mitral valve, the aortic valve. And this is that thick wall of muscle between the right ventricle and the left ventricle called the septum. And so the goal is how do we get rid of that? And so we cut this muscle out. It's heart surgery. So usually we open up the sternum. There's different ways to do this. You don't necessarily have to open up the whole breastbone, but you have to get access to the heart at some point. And you have to go on a heart-lung machine, and we have to stop your heart to do this. This is pretty standard, everyday kind of heart surgery to do that. And then we make an incision right here in the aorta, and we push these the valve, the aortic valve. And if you look over on the right side of the picture here, you can see the aorta is opened. And what you're doing is you're looking right inside the heart. You're looking down into the heart, and you see this big hunk of muscle right here. So this is the valve that's being retracted up in this cartoon. And this right here that says AMV, that's the anterior mitral leaflet. If you go over on the left side picture here, that's what this is. And that anterior leaflet is what gets caught and pushed up against this wall here. And when Omar said the word SAM, that is when this leaflet, during systole, when the heart is contracting, pushes up against this wall of muscle and therefore obstructs the outflow coming out of the heart. So the goal is to cut out this muscle, but very importantly, the extended septal myectomy, it's very important to free up all this muscle that's way down here. These are called the papillary muscles, and this gives up parachute cords that go up to the mitral valve. And in order to deal with the mitral valve, you really need to free up a lot of these muscles to allow that mitral valve to have more normal function. So when you go back into the surgical side and you look back over on the right side, there's a lot of important anatomical structures, and this is probably more meaningful for the providers that might be on the line as opposed to the patients. But nevertheless, this is important because it relates to some of the complications that can occur after doing this operation. It's very important when you see this muscle is going to be cut out. But there's some important structures, and one of them, where that little star is where the electrical system of the heart works. And, you know, there's no way to do this operation well without taking away some of the conduction of the heart. And I look at the conduction system as kind of like, you know, telephone pole wires going down the side of a highway. And we're going to bend some of those wires. And we might even cut some of those wires, but we don't want to take out all the wires. Otherwise, you need to go see Dr. Bunch and get a pacemaker put in after surgery. And certainly that is one of the risks with this operation, is needing a pacemaker. Because sometimes in order to do an adequate debridement of all this muscle, you have no choice but to go in to or close to the area where this conduction is. Obviously, if you go and it's too, your cut is too thick. So here is a cartoon now on the right where you can see there's a scalpel that goes right below this aortic valve, and you have to be careful not to get too close to that valve because otherwise you could cause it to start to leak afterwards. And you can see a knife is going and cutting this area right here, which is going down into the left ventricle here. This is a little hook into this, and it's going down into the ventricle to cut out that muscle. And then as we spoke, when you look down inside in this picture right here, this cartoon right here shows you this anterior leaflet of the mitral valve and these parachute cords that we call the chordae tendineae that go down to the papillary muscles. And what you want to do is we need to free up all of that papillary muscle. You can see in this little cartoon with this disease process with the hypertrophic cardiomyopathy, a lot of times you have abnormal muscles that will attach in weird places. And so we need to take those apart. So this is an example of what we call an accessory papillary muscle that's going on to the anterior leaflet of the mitral valve and can impede the ability of that mitral valve to work efficiently. So it's very important. The original Morrow procedure just cut a little bit of muscle, but it's important that we cut a little bit of muscle, actually in many cases a lot of muscle, but also work down below into the subvalve, what we call the subvalvular apparatus, to free up that mitral valve. There's other ways to approach this besides going through the aorta. This is a way that we go through the mitral valve. And so this is kind of getting a little surgery 303 here, but it's just one slide, so bear with me. This is the anterior mitral leaflet, which is brought forward. And just like we showed on the other slide, that anterior mitral leaflet is hitting abruptly the muscle. And so when you bring in this cartoon here, the anterior mitral leaflet forward, what are you going to see? This is the septum. And so therefore, then you can cut this and then reattach that anterior mitral leaflet. I'll be honest with you, this is not a very popular approach. There are some times when you might want to use this approach, but it's not a very traditional approach. What do we do in the operating room? So when you're in clinic and you're getting your echo, they're going to ask you to bear down. And we can't do that when you're asleep on the table under anesthesia. And so we use different kind of medicines to kind of rev your heart up. And we do other things. When you're asleep, we can actually have you bear down by having you take a deep breath. We force you to take a deep breath, which is the Valsalva breath. And then what we do is we can have direct monitors, pressures in your heart and in the aorta. And you can see when we provoke, we'll try to make your heart skip a beat. That's what this is right here. These are normal beats. If you look at the top here, here's a skipped beat right here. And after the skip beat, you don't feel that heart very much. And therefore the gradient goes up. And that's what you see here. The gradient is the difference between this peak of the pressure tracking and all the way up here. And after you do surgery, you want to do the same thing. So we have pressure monitors, and you can see that the blue and the brown are the same. We do that fancy thing where we tickle the heart, make it skip a beat, and lo and behold, after the operation, you can see that there is no gradient there. So that helps us feel good about the results of the surgery before you leave the operating room. We don't want to leave the operating room with you having a pressure tracing like this. Obviously, we're going to use the ultrasound machine when you're asleep to make sure that we leave without having a significant gradient. There are complications that occur that are very important. And when you're sitting in our clinic and we're talking about this, we have to be very open and honest about it. There's a risk of stroke with any heart surgery. There's a risk if you cut the muscle too much that you can get a connection between the left side and the right side. That's called a ventricular septal defect. As we talked about, you can have heart block that occurs afterwards. And finally, if you get too close to this valve, you can cause a leaky aortic valve. Fortunately, the chances of that happening is quite low. As Lisa mentioned, in experienced centers, you should expect a mortality without having a lot of other medical issues below 1% for this operation. And the complications should be below 5 to 10% with this operation as well. So what about the mitral valve? I'm not going to perseverate on this. Actually, I'm going to just skip this. It's an important piece that we need to understand and deal with. And there's a lot of very experienced myectomy surgeons that do not feel that strongly about dealing with the mitral valve, and in many of their experiences say that the mitral valve actually only needs to be addressed in less than 5 or 10% of the patients. At least the kind of disease that we're seeing now, I must admit that I think doing something on the mitral valve is probably more than 5 to 10% of myectomy cases. And it's something that really needs to be considered. And what you see here is the left atrium. This is that mitral valve, and where it sneaks over, and it basically obstructs completely the outflow coming out. And so there's a lot of different ways to deal with this. And my typical approach, and the way that Omar and I have been dealing with these patients, are if you don't have a really, really thick septum, but you're having LVOT obstruction because of this anterior motion of this mitral valve, you probably need to do something real about that mitral valve. That just cutting some muscle is not going to be enough. This is an example of an echo, which is what Omar showed you beautifully, but these are going to be some still frames. So here's the left atrium, here's the left ventricle, here's the outflow tract, this is the aortic valve. And you can see this big thing right here. This is that mitral valve that is not supposed to be there when the heart squeezes. So blood is trying to get out this way, and it just can't do it. And so what you see is when you put color on this, you see this very turbulent blood flow. And so that's having trouble getting out of the ventricle. And in addition, it's also causing a lot of mitral regurgitation or leakiness of that mitral valve. And where is that going? That blood flow is going right back into the left atrium, which is the left atrium is the mudroom for the lungs. The lungs come out of the cold and then drop blood into the left atrium before it comes in to the left ventricle. Jared's probably going to use that against me later on, calling the left atrium the mudroom, but maybe we'll see what he says. Anyway, if we do a myectomy, and then you can see by doing the myectomy and then doing a little bit of application of the anterior leaflet of the mitral valve, you can see that there's not a whole lot of crazy color coming across this, which we call laminar blood flow. So there's not obstruction coming across. And at the same time, you don't see any mitral regurgitation. So we feel that this was a pretty good repair for that patient. Here's another patient with a similar problem where you can see the same kind of color play, where it's having trouble getting out of the outflow tract here on the left, a lot of bad mitral regurgitation. And similarly, after repairing this valve, you can see that, and it wasn't big time muscle resection that we had to do, but by doing the muscle resection as well as repairing the mitral valve, you can see nice big blood flow coming out the outflow tract and basically minimal mitral regurgitation. So dealing with the mitral valve is very important. I talked about this latent HOCM. I'm going to just kind of keep moving on. There are some other things that come up in our conversations because of the mitral valve, including this thing called the MitraClip, which is a catheter-based approach to get to the mitral valve and try to clip the anterior leaflet to the posterior leaflet. Like you see in this image way down here, this is the anterior leaflet where my little hand is. The posterior leaflet is here. And the clip brings the two things together so that it stops it from going out into the outflow tract. And the MitraClip is actually a pretty good option for people that have mostly the systolic anterior motion component of the LV outflow tract obstruction, especially if they're not very good operative candidates. If they have a lot of other comorbidities, maybe they've had other heart surgery or whatever things that might make it more risky to go down that pathway. Omar mentioned the different types of hypertrophic cardiomyopathy that's not just up at what we call the basal septum and near the outflow tract, but it's also in the mid cavitary or in the apical cavitary. So here's an MRI image where you can see all this muscle. Basically, there's no cavity here. And what we can actually do is what's called a transapical myectomy. So instead of going in through the aorta, we actually make, and I'm stealing this picture because it's such a beautiful picture from the Mayo Clinic publication, but you make an incision in the left ventricle itself, in the apex, and you basically core out this muscle. And so that's what you can see here. And that can be quite satisfying in terms of allowing for more blood into the heart. That's called a transapical myectomy. Now, the thought is, well, if you have obliteration of the cavity, let's make it bigger. And the question is, well, is that better than just saying, okay, we can't do anything, let's do a heart transplant? And so here's some clinical outcome data. And I think probably the most important thing is over here. When you look at health status, afterwards, 70% plus are feeling a whole lot better after this. And then when you look at their functional capacity, you would prefer to be less yellow. That's when you really can't do much at all, and be more on this side, the blue and the red. And so people can feel better after this rather than necessarily going to a heart transplant. There was a mention of alcohol septal ablation. This is a very center-specific and provider-specific therapy, and it's also patient-specific. Basically, what you're trying to do is a controlled heart attack by putting ethanol down a blood vessel that goes into that thick muscle. And it's really dependent on the anatomy so that you actually have a good coronary vessel that goes in that region. And that's kind of what you see right here. There's a blood vessel that comes off the left-sided circulation that goes down there. And geez, if you basically fry with ethanol this part of the muscle, it's going to die. And when that muscle dies, it retracts and it creates scar, and it decreases its size. And it can be very helpful, especially folks that have this very proximal or basal septal hypertrophy and have a blood vessel that goes to that area. It has a lower risk of stroke than surgery, but it has a higher need of pacemaker, and it's probably just not quite as effective in terms of needing re-intervention, as you see here on the side. What are other surgical therapies? There are these machines, these heart pumps that are called left ventricular assist devices that go into the heart and they spin blood out of your left side of your heart and then attach it to the other side, to your aorta. This is called an LVAD. This is probably not the best therapy for patients that have HCM. Mostly because the ventricle is so small and the diastology restriction component of the heart and its an inability to really relax it really is not in our top choice of anything associated with this, but I provide it as an option. And finally, heart transplantation is in the algorithm for these, especially the patients with non-obstructive HCM that really have no option, failed medical therapy. And indeed, the outcomes with transplantation, and this is an article that Omar put together for us that looked at data comparing patients with hypertrophic cardiomyopathy, ischemic cardiomyopathy, and non-ischemic cardiomyopathy. And you can see that the percent survival with HCM after transplant is quite good, and it is actually better, or at least as good as other diseases. So I think what I'm going to do is try to wrap this up, and I'm not even going to go over the slide. I'm going to just say thank you again to Lisa and the HCMA group, and I'm going to stop sharing and let Jared get busy.
Thank you very much for that great talk. And I always feel obligated anytime anybody invokes the name Morrow to give the history lesson associated with it. And for those who don't know, Dr. Morrow actually created the myectomy procedure. He was a surgeon at the National Institute of Health in the late 50s, early 60s, where he perfected this procedure. And at the same time, Dr. Eugene Brunwald diagnosed him as having the disease, which is hypertrophic cardiomyopathy. So the physician who created the surgery that treats thousands of HCM patients actually had HCM himself. So just one of those little, can't make this thing up. So without further ado, I'm going to bring Jared Bunch to the screen, who I think I originally met you in a restaurant in Bethlehem, Pennsylvania.
We did?
We did, yeah.
Good memory, really good memory.
Yeah, and Julie lives in Bethlehem, so we were right down the street from her house when we did that. So, it all just comes full circle. It's all about Bethlehem.
Yeah, exactly.
Okay, so if you want to share your screen, and Jared Bunch is an electrophysiologist and speaks nationally on all matters related to EP, but we're going to be focusing on atrial fibrillation and HCM, which is a really complicated topic. So I'm really happy he's taking this on. So without further ado, Jared, it's all yours.
Lisa, thanks so much. And this is just such a tremendous organization. And like I said, we were part of in Bethlehem and the Lehigh Health Network, a symposium similar to this a decade or more ago. And at that time, we wanted to bring specialization of this to Utah. And that was a lot of that discussion that night. Now we have wonderful specialists and genetic counselors here to really treat it in a comprehensive way. And I'm an electrical doctor. You'll hear plumbers and electricians. I'm on the electrician side of things, so I can help you a lot with electricity, but when you need good plumbing, I can help you find somebody that can do better. And if you're not sure about what atrial fibrillation is, we put together this whiteboard presentation because for some people who have been inflicted with it, they know quite a bit about it, or they have a family member, but for others, it may be a foreign topic. So I'm going to play this for you really briefly.
If your heart races sometimes for no apparent reason, you stay fatigued, get dizzy or weak, or can't seem to catch your breath, you may be one of the more than 2 million people with atrial fibrillation, or AFib. Atrial fibrillation is a common heart rhythm disorder caused by an electrical system problem in the upper chambers of the heart, or atria, which causes them to beat quickly and/or unevenly. It can be a serious condition that affects your heart's ability to fill with blood normally and can put you at a greater risk of stroke or heart failure, but it can be controlled with treatment and close monitoring. An ECG, or event monitor, will easily diagnose AFib. Some people with AFib need to take medications to keep their heart rate in a normal range, and/or blood thinners to minimize the risk of stroke. Basic lifestyle changes like diet, weight loss, and exercise can be effective for managing AFib. A number of treatments for AFib can help improve symptoms and get you back to a normal lifestyle. This may include medications alone or procedures like cardioversion or cardiac ablation, which is minimally invasive and can help the heart stay in normal rhythm. If you think you may have AFib, contact University of Utah Health Cardiovascular Center to set up an evaluation and get appropriate treatment.
All right. And why is this so important? Well, in general, just as this mentioned, this is a worldwide problem. In fact, as you can see in this graph, how it's growing substantially. As now we're in 2020, it's almost doubled over the past 20 years, and it's expected to grow further. And when we can look in a community like around Mayo Clinic, it's even higher than we're projecting with typical statistics. And what does that mean for you? Well, if you live to be over 70, there's a 1 in 3 chance that you'll get atrial fibrillation with or without hypertrophic cardiomyopathy. And if you have a family member with it, that rate goes up to 50%. And this is becoming a global epidemic in both developed and underdeveloped countries. Well, why is it so important with hypertrophic cardiomyopathy? All those things that have been discussed today, the thickening of the ventricle, the enlargement of the left atrium, people with hypertrophic cardiomyopathy have a much higher risk. And not only is the risk higher, but here we can see in total, the green, that people develop atrial fibrillation earlier with hypertrophic cardiomyopathy. The average age, if you don't have that, is in the mid to latter 60s. We would see a fair percentage of younger people, well over 50%, that are under 60 with hypertrophic cardiomyopathy that develop it. And that means that we have to not only diagnose it quicker, but treat it more appropriately earlier to prevent some of the consequences of atrial fibrillation. So what are the risk factors in hypertrophic cardiomyopathy? And this is a large group that looked at that. And what an odds ratio means is what's the likelihood if you get it. So 1.0 means no likelihood, and 2.0 means twice as likely. So if your age of diagnosis of hypertrophic cardiomyopathy is over 50, you have a 3-time risk. If you're in more advanced heart failure, it's almost 4 times more likely. If that left atrium is enlarged, as talked about, you're 3 to 4 times more likely. Those are important risk factors for the development of this. And so what does it look like? Well, here's a schematic that we've shown today with the left ventricle with the hypertrophy and the cavity chamber being smaller. This puts pressure on this thin left upper chamber. And as Dr. Salzman pointed out, often there's regurgitation that even enlarges it more. And what happens when the chamber is under pressure and enlarges, all those areas can fire abnormal electrical signals, particularly where these veins enter the left atrium, and that can lead to atrial fibrillation. And we can precisely predict that by the size of the left atrium, and as it goes up over time, you can see in almost a linear manner, the risk of atrial fibrillation goes up. So you have moderate enlargement, there's about a 30% chance in the next 5 years you'll develop atrial fibrillation. If you have moderate to severe, it's upwards to 40% likelihood of developing atrial fibrillation. What are some of the other risk factors? Just the same things we've talked about today, just severe diffuse hypertrophy, scar or fibrosis in the septum, and what we call restrictive physiology, meaning the ventricles even getting more stiff and having a harder time opening quickly to return the blood flow. So what does it mean for you? Well, it's very important as diagnosis of atrial fibrillation as that impacts your survival. If you're in a normal rhythm, you can see survival is quite good. But when you develop atrial fibrillation, 30% mortality risk at 10 years. So we have to identify this rhythm quickly, and how we treat it is important. And not only that, if you have obstruction here in green, that mortality risk even goes further because your heart can't tolerate the fast rhythms of atrial fibrillation and the lack of communication, electrical communication between the upper and lower chambers. So how do we treat it? Well, this is the general guidelines to maintain sinus rhythm, which is a normal rhythm. And what electrical guys like me do is we take somebody and we say, well, do they have heart disease? Do they have coronary artery disease? Do they have high blood pressure and heart failure? And based upon those, we decide which medicine you can take, or some of these surgical or catheter-based procedures that are available. Now with hypertrophic cardiomyopathy, we're immediately restricted from this arm, particularly if there's substantial left ventricular hypertrophy. So our options, as you can see, go down to one drug. And if you have heart failure, instead of all these drugs and options, you have fewer drugs and fewer options, and a quicker pathway to potential procedures like ablation. These guidelines were updated in 2014 and really imply the same thing, that if you have heart failure, then there's just a few drugs that are available, and catheter ablation becomes critical in the management of this. So this is the challenge that we see, and this is our strongest medication, called amiodarone. And if you have atrial fibrillation and hypertrophic cardiomyopathy, you probably heard of this drug. But this is 52 patients that had hypertrophic cardiomyopathy and atrial fibrillation, and 90% were symptomatic. And this may seem intuitive that everyone would be symptomatic, but about a third of our patients with atrial fibrillation without hypertrophic cardiomyopathy are completely unaware of it. But people whose heart's stiffer, they tend to have worse symptoms earlier. And so that's why that high number. So if we look at the people that maintain sinus rhythm and normal rhythm early, we can do it in about 56% of the time. But if you follow those people, you see it goes down to 40%. And those patients that are in atrial fibrillation, most tend over 5 years to stay in atrial fibrillation and have it progress. And the one medication, amiodarone, is the one that tended to predict our ability to keep you in a normal rhythm. Amiodarone here is another trial of hypertrophic cardiomyopathy. It looked at 45 people, and 9 of which were on amiodarone. It worked in 8 out of the 9 patients. The others developed another abnormal rhythm called atrial flutter. It's a sibling of atrial fibrillation. But one of the problems with amiodarone is, even though it worked in 90% of the people, 3 of the 8 ultimately discontinued it. That's because amiodarone has a lot of side effects, including inflammation and injury to the liver, the lungs, the thyroid, and nerves. And so people on this medicine are getting frequent blood tests twice a year, and lung tests once a year, so we can pick up early signs of inflammation and stop it before permanent injury occurs. Well, there's other medicines, and this was one that's not in our guidelines. It's called disopyramide, and what disopyramide does is relieve that obstruction. Here's the average before, about just below 80, and the average after is 40. Not only does this medicine have the ability to relieve the obstruction, it also helps organize the electrical signals in the upper heart chamber. And people on disopyramide, because it helps with that obstruction and the abnormal heart rhythm, they tend to do better. Remember, the survival curves before atrial fibrillation, about 30% at 10 years had passed away. But those on disopyramide, in which the outflow tract obstruction was minimized and the rhythm was controlled, then that changed to 10%. And why don't we use it all the time? Well, it has a lot of side effects. It can dry our eyes, our mouth, cause tremendous constipation, for males, it can cause prostate obstruction as well. So there's a lot of side effects, and we often do start it in the hospital just to be careful with changing the outflow gradient in our people that are vulnerable and have blood pressures that are also somewhat borderline. Well, there's another medicine called sotalol. And this isn't in the guidelines because it's been listed to be contraindicated in people with very sick or very thick left ventricles, but it has been studied in those with hypertrophic cardiomyopathy. And there were 30 patients, 7 of which were placed on sotalol, and 6 of the 7, it worked quite well. In only 1 of the 6, it was discontinued because of side effects. And what was interesting about this medication is it was improved exercise time in 83% of people. Just like Omar said, with a stiffer heart, it needs longer to fill up with blood. And sotalol is a beta blocker that also controls the electrical rhythm. So it does help increase the time to fill with blood and make that heart more efficient. What we do have to monitor closely is what we call the QT interval. This is the upper chamber electrically beating, and this interval from here to here represents the bottom chambers being coated with electricity and then recovering. And if this QT interval prolongs too much, we can't use it. And so people come in for sotalol usually for 2 to 3 days in the hospital to monitor this QT interval. And just a few months ago, intravenous sotalol was approved. And so this time in the hospital may be shortened. But if we don't watch it and follow it, then about every 6 months, you can be vulnerable to abnormal rhythms from the bottom heart chamber that can be life-threatening. So this is a drug that requires careful monitoring to be used safely. And also, as mentioned, if used safely and effectively, it can help you feel better and improve your exercise time. And this is the other drug you saw in there. It's called dofetilide. And it is a medicine that doesn't slow the heart rate down, but has been shown in heart failure, patients with either heart failure from a stiff lower chamber or a weak lower chamber, to work quite well and be safe. And here it's about 60% effective in 3 years at controlling the heart rhythm and keeping you in a normal rhythm. It also impacts the QT interval. We have to follow it even closer. And people on Ticastin, we have to check this every 3 months and if we don't, there's about a 2% risk of these abnormal rhythms. The other problem with dofetilide is it just became generic, and there's only one company that makes it. And so a non-generic dofetilide is called Ticastin, and it costs over $200 a month. Generic dofetilide costs about $80. So with all the medicines that can be used, what we like to in our mind is make it the most simplistic for you. And unfortunately, amiodarone, the one drug, is the only drug that helps your heart stay normal that's once a day. But it's also the drug that has the most side effects. The other two that we can use with hypertrophic cardiomyopathy in select people are twice a day, and there's side effects of that QT prolongation that we have to be careful with. And sotalol, because it's a beta blocker, it can cause a slow heart rate and a depressed mood as well. And as mentioned, disopyramide, it's twice a day, but it has a lot of side effects, and because of that, it's not often used. We have to also consider how these drugs are broken up. And so these are drugs that control the heart rhythm that mainly go through the liver. These are mainly go through the kidney, and of these are the two we talked about, sotalol and dofetilide, and the amiodarone is broken up by the liver. And people that use amiodarone, it will interfere with many other drugs, including blood thinners and things like that, that also are broken up by the liver. These drugs don't impact the kidney function at all. In fact, you just urinate them out. But if there's changes in the kidney function at all because of some aging or some other problem, these drugs quickly build up in our bloodstream. And then disopyramide, the other drug we talked about, it's cleared by both the liver and the kidney. So it can be impacted both by drugs that impact liver metabolism and kidney excretion. So what's catheter ablation? Well, catheter ablation, this is the left atrium and these pulmonary veins that drain the blood that's oxygenated from the lungs to the heart. And most of the time, we can't work in the veins because they're delicate. So we go with a catheter through the vein in the leg, and we cauterize in these little precise lines around the veins and separate them electrically from the heart. People that have hypertrophic cardiomyopathy, because there's a lot of stretching of this upper chamber and scar, this procedure is often increased or augmented, where we add additional lines. And this is based upon surgical procedures called the Mays procedure to separate the heart into different chambers electrically and wall off its ability to create abnormal rhythms. With catheter ablation alone, it works at about 75% of people at 1 year with drugs, and about 62% at 1 year without. Now, drugs themselves, they work about 40 to 50% at 1 year. Here's another. This was a study we did at Mayo Clinic. This was another similar study showing after ablation, 52% were in a normal rhythm, 48 had recurrence. And of these patients, some required a second and third ablation, ultimately to be free of abnormal rhythms. But with more than one ablation and drugs, and about 90% of people were in a normal rhythm. But it's important to realize that ablation is typically not curative, and this highlights it, that sometimes, just like if you get cavities filled, you can get new cavities elsewhere. You can get new parts in the upper chambers that cause atrial fibrillation, and for that reason, sometimes we do a more aggressive procedure trying to wall those off. So, and this is why, because in the heart, when we look at left atrial enlargement, as the heart gets bigger, you get all these little blue areas in the healthy red muscle. And these areas represent scar. And what electricity does is it doesn't go through scar. It hits the scar and starts going around it, causing these little micro short circuits. And that's what causes atrial fibrillation. Just the same if you watch streams or creeks with rocks in them where eddies form. That's the same thing that's happening in your heart. So what did we learn recently? And this is a little bit busy trial, but it summarizes a trial called the East AFib trial. And it was a trial of over 2,800 people. And these are people that had atrial fibrillation diagnosed in 1 year. And what they wanted to say is, should we just watch you for a while and treat you for everything else? Or should we be aggressive and start you on a medication, or here in light blue, do an ablation early? And what they found was in people that had that early strategy, that over 8 years of time, you can see that they did better. They had less death, stroke, heart attacks, and heart failure hospitalizations. So it's changed our strategy. And if we're going to do something about this abnormal rhythm, we want to do it relatively early. And this data suggests that that first year is critical. And in almost everything, this early rhythm control versus usual care, we can see stroke and death and adverse event and cardiac arrest, and things were lower, with the exception of the medication sometimes required to get you there can cause a slower heart rhythm or this abnormal rhythm from the bottom chamber. This is a trial that I was involved with for 2 decades of time, and a lot of people say, well, what will you do? What would you do? Would you do medications first, or would you do an ablation to get your heart in a normal rhythm? And this trial asked that very question in 2,200 people. And over 5 years of time, you can see catheter ablation. And these are people in a normal rhythm. About 50 to 55% of people at the end of the study were in a normal rhythm after ablation, compared to about 35% who were on drugs. So catheter ablation is twice as effective as drugs in maintaining you in a normal heart rhythm. That's not to say drugs are bad for you, because everybody responds different. But if you're looking at the beginning, one therapy is more effective than the other. And this was a breakdown of which groups in that trial tended to do best. And of these groups, if you're on this side of the line, you do much better with ablation. And on this side, you do much better with drug therapy. We can see that younger people compared to older people, men compared to women, and those with heart failure were the ones that tended to do quite a bit better with ablation. Now, with women, one of the important things to realize is oftentimes women are referred a little bit later for therapies. And in this trial here, where women had to be referred within 12 months, they did just as good as men. So, but if you want to say if you're an ideal person, I'd say that you're a younger person with heart failure, as far as doing much better with medications or with the ablation compared to medication. It's important to know that atrial fibrillation is a continuum. So this is somebody without atrial fibrillation, little episodes, and then it becomes more frequent. And this is driven by alcohol use and activity, being overweight, high blood pressure, and other diseases. If you want to push this back the other way, don't smoke, get your diabetes treated, be active, don't drink or reduce substantially any drinking, treat high blood pressure. Now, some things with hypertrophic cardiomyopathy are independent of your blood pressure, but if you have a combination of hypertrophic cardiomyopathy and early hypertension, that accelerates things. So these are things you can do. These are things that can help minimize the progression of atrial fibrillation. And kind of wrapping up, our biggest worry with atrial fibrillation is this, and this is our brain. Dark tissue is healthy. And here you can see this big mass-like lesion. And this is somebody that had a large stroke and it affected the part of their brain where they speak. And so weren't able to speak and communicate after. And one of the biggest complications of atrial fibrillation is risk of stroke. And in people with atrial fibrillation that develop a stroke, their strokes tend to be bigger and cause more morbidity. And so in people, in general, we use a score to determine if you need a blood thinner. And a blood thinner doesn't thin the blood, it just makes it less likely to form a clot quickly. But it's the same viscosity as normal blood, it just doesn't form a clot quite as quickly. And if you have 2 or more of these risk factors, we recommended long-term anticoagulation. So if you're over 65, over 75, if you've had a stroke, if you're female, vascular disease, hypertension, diabetes, or heart failure. If you have 2 or more of these, we recommend long-term anticoagulation. But what's important to know is hypertrophic cardiomyopathy is equivalent to at least 2, and it's probably 2 to 4, and you're at higher risk. So everybody with hypertrophic cardiomyopathy that can take blood thinners, we recommend early use of blood thinners. And what we're found in this institution, and now it's been replicated in Europe, is we need to start them within the first few years of atrial fibrillation, or not only your risk of stroke is higher, but your risk of dementia and cognitive decline goes up. So we want to start those early, and we consider you at least moderate risk and need just from the presence of hypertrophic cardiomyopathy. So where should you go to get treated? Well, if you have atrial fibrillation, there's a lot of people involved. We're the electricians, but we have cardiology, the emergency room, neurology, we have anticoagulation clinics, we have surgeons, dietitians. It takes a team, and everybody is integral to help you through this process. And when everybody's involved, you do better, you feel better, you live longer, the complications are lower. And so if you're in, just like hypertrophic cardiomyopathy, we also have atrial fibrillation centers of excellence, and they tend to go hand in hand because these are centers that are committed to teamwork. But we want you to be involved in the process. We want to educate you. We want you to be empowered. We want to do shared decision making so we can talk through the risk and benefits of the different approaches and treatments. We need to offer you all the approaches from catheter ablation. And the surgeons can do something very similar to what we do. And there's a role for each. When to use blood thinners, how to get through lifestyle changes and who can help you with them. And also have the appropriate tools and support from the system. So all of these are critical. And Lisa and the HCMA can help not only guide you to these centers of excellence for hypertrophic cardiomyopathy, but also for atrial fibrillation centers. And the Heart Rhythm Society keeps these online to help you as well. So I want to stop there, and I appreciate all of your time tonight and the great people that have had the pleasure to share this symposium time with. Oh, I can't hear you.
I'm on mute.
I got you. There you go.
The 2020 t-shirt is "You're on mute," and we all just point down at the t-shirt at this point because it's happened a billion times. So that was a fantastic presentation. AFib and HCM is an incredibly complicated topic, and I'm often asked, when do I move to ablation, and do I have to take these antiarrhythmics, and do I really need anticoagulation? And they're all intense conversations, because we don't want anybody stroking, and we don't want anybody having impaired quality of life. So I've had a stroke, not from atrial fibrillation, so I can just tell you, you don't want to do it. It's not something that you want to put on your things I've done list. So try to avoid it as best as possible. And please go to high volume care. I love your puzzle pieces for AFib management. I should overlay that into my funnel of HCM care, and it would add to the story. Okay, so next up in our tour, we're going to hear from Holly Andrews. Correct, yes, because I have the right agenda in front of me now. So silly. So we're going to talk about how the program is functioning and how people can get involved with you, and a little bit of, understanding of what the program is all about. So Holly, why don't you tell us all about it?
Thank you, Lisa. Here we go. Okay, so I am thrilled to be speaking about our hypertrophic cardiomyopathy program here at the University of Utah. Just a couple things about the U just in general. We are we're a big system here in Utah. So we have our main hospital, we have 4 hospitals in general, there are 12 community clinics. We see a large surface area, continental surface area for the US, over 10% of the continental US, mostly the Intermountain. We see patients from lots of different surrounding states. We have over 1,400 providers here, our own health plan. Part of what we do at the U is further research. And so we get lots of, awarded grants and funding for further research. We do more education. We have a School of Medicine, College of Nursing and Pharmacy, Dentistry, College of Health. So there's a lot of action going on here at the University of Utah in general. At our hospital, we have 630 staff beds. During a year, we can have up to 58,000 plus ED visits, 36,000 admissions over the year. We do over 34,000 surgeries, 217 transplants was recorded for one of the years. There's a lot going on here. One of the other things too, just from recognition, this year as well, we're a top 10 for quality among academic medical centers, 8 years in a row by Vizient. So there's a lot going on at the U. Specifically though, we want to talk more about our hypertrophic clinic. So at the U, 50% of our patients come from more than 100 miles away. And specifically in our clinic, we see patients from currently 7 different states in the Intermountain West. To be able to accommodate that, we have both in-person visits and telemedicine visits now to be able to see those patients. So every single visit doesn't have to be a trek over to Salt Lake City. It can be telemedicine as well. And for those patients specifically who are coming from really far away, it's going to be an overnight stay. A lot of times we do testing and those types of things. We work very hard to try and consolidate all the testing and appointments patients would have all to be on the exact same day for their convenience and so they don't have to travel multiple days. Something else I want to touch on briefly, in that Lisa already went over it tremendously, is the Hypertrophic Cardiomyopathy Association, an incredible association, and what they do for patient advocacy is amazing. They've designated us to be a hypertrophic cardiomyopathy center of excellence, and we're very excited to be able to be partnered with the HCMA in that standpoint. Now, why are hypertrophic clinics needed? And we've gone over quite a bit of this already, and just want to touch again a little bit. So prevalence, Lisa and Dr. Weaver-Pinzone already talked about it, but 1 in 500 people, maybe more realistically, 1 in 200 people have this. And one of the most insidious things too about the disease is that there's a risk for sudden cardiac death. So what we're looking at is it's really prevalent. There's, some terrible complications that can happen to a small portion of these patients. So we need to try and figure out who they are. But specifically, there's a whole range of treatment needs for these patients. You have patients who can go their entire lives without any symptoms, and they, find out they have the disease just incidentally. And you have all the, a spectrum of people needing defibrillators, medical therapy, surgery, all the way up to heart transplant. And so where they land in between, or where they need all, what type of treatment is where a hypertrophic clinic is needed. And so who should have a visit with our clinic? So first of all, anyone who has ever been diagnosed with hypertrophic should have an appointment with us. Anyone who has a family member, because it is genetic, it means that it can show up throughout the family. With that, it also doesn't have to show up right away. It can show up anytime during life. So even if you don't have symptoms now, if there's a family member, you should get screened for the process too. Anyone who has a questionable diagnosis of HCM. So what I mean by that is there's thoughts that the ventricle is thicker than it should be. There's other disease processes that can mimic hypertrophic for example, something called Fabry's disease, or if you have high blood pressure that hasn't been treated for years and years, it can cause thickening of the ventricle. So anyone who has a questionable diagnosis should come too, so we can kind of tease out what's going on. Anyone who wants a second opinion, we're happy to see as well. And anyone who their hypertrophic cardiomyopathy has progressed to heart failure and their quality of life is not where they would like it to be, we can see them as well for an advanced therapies evaluation, such as heart transplant. Now, how do you get an appointment with our clinic here at the University of Utah? There's multiple avenues for that. The first is you can have a referral from a medical provider. You don't have to have a referral, but that's one way to go about it. The other is calling our clinic. So we've got the number listed here. You can call and request a visit. And the others, we have an email. And then later on in the program too, I'll have the website for you, and you can get on and request an appointment there as well. So those are the ways that you can contact us to get an appointment with the University of Utah. Now, what if you are one of those patients who is coming from, say, Montana or New Mexico, and it's going to be an overnight trip? Where do you stay while you're here? So the University of Utah actually has lodging coordinators who are available 24/7 to be able to talk about housing options for you. The way you can get in contact with them is if you're already here in person, you can just walk in the front of the hospital in the main lobby, and they're at the information desk. You can also talk to them by phone, the number's listed there, or by email. Again, they're available 24/7. A couple places we have, just to go over a few, we have the University Guest House that is attached to the campus of the hospital and has a shuttle running from it to the hospital. We also have patient and family housing and the Marriott University Park Hotel, which is on campus as well. The U is also partnered with apartment complexes and other hotels in the city and in the Valley area to be able to have discounts for stay. Going over the list, looking at it, they range anywhere from about $50 a night and upward, depending on where and what you're looking for. And so again, those lodging coordinators can help with that as well. The other thing to be aware of is, what if somebody speaks a language or a different language other than English? At the University of Utah, we have Spanish interpreters that are on staff to be there for any clinic visit. Any additional interpretive services that are needed, we have a MARTI system, so we're able to accommodate almost all languages, so most languages for those patients, and these services are free. How do you set it up? So the first way is when a patient calls or contacts our clinic to get an appointment, they can, one, have an interpreter over the phone, and two, can just let our schedulers know and we can get it set up for the visit. And two is there's a number I have listed on the screen there that they can call the interpreter services themselves, and then it will be put in their chart that they need an interpreter in which language, and we get it set up for that visit. Now, who are you going to see when you come to your visit? So the Hypertrophic Cardiomyopathy Clinic, you're going to see Dr. Weaver-Pinzone and or myself. Dr. Weaver-Pinzone's our medical director for the program. Now, when we talked about the whole range of treatment options for patients, depending on their symptoms and where they lay on that spectrum, we would have you meet some of the other people as well, two of which have been a part of this program tonight. So Dr. Selzman is our surgical director for the HCM program. For interventional cardiology, if somebody needs a septal ablation, then that's Dr. Welt and Dr. Smith. For genetic counseling, you're going to hear from Ivana here soon. But for genetic counseling and genetic testing, you'd meet with Ivana. For our electrophysiology team, Dr. Bunch already spoke tonight, but we also have Dr. Navarvong and Dr. Steinberg. And then if you or a family member has a pediatric patient, so a child who you either suspect has hypertrophic or you want to have screened, we are also partnered with Primary Children's Hospital, their UCHANT program, with Dr. Ashwin Lau. We can get you in contact with them as well to have a visit there for your child. Now, what are you going to expect at your visit? So I want to break this down into two different visit types. Your first visit ever with our clinic as a new patient is a pretty intense visit. We go over a lot. We go over your history, we go over your symptoms, and then we start an evaluation. So first and foremost, because 1% of all hypertrophic patients are at risk every year for sudden cardiac death, we do a sudden cardiac death risk evaluation. So that includes an EKG, that includes cardiac monitoring, so something called a Holter monitor, to be able to look and see kind of what your risk factors are there. We also need imaging. We need to see what your heart looks like. We need to see how thick it is with the scarring tissue, if there's scarring there as well, if there's obstruction. And so that's echo and MRI. Genetic counseling, and you're going to hear from Ivana next, is a very important part of all this, since it is a genetic disease, and trying to figure out, family member wise, or, looking for the future too for new genes and what gene might be there or might not. And then at the visit too, we usually get blood work. And one of the other things that we offer is something called MyChart. So MyChart is an application the University of Utah uses that allows the patients to connect with their medical record. So no longer do you have to go into the medical record physically in the hospital to get your information. MyChart is a way to get it digitally. So we set you up with it, and you can see the notes from your patient visit with us. You can see your test results. You can send Dr. Weaver Pinzone and I a message on MyChart. You can set up appointments and cancel them. So it's a really easy way to access your medical record. You can use it on a computer. There's also apps you can download for your phone so you can have it in your hand. And for those of you that also have children who you want evaluated to, the pediatric patients, you can actually get your pediatric children attached to the MyChart as well. So you can see your record and their record for those under age 18. And then follow-up. New patient visits are usually pretty quick follow-up. And the reason is that we have all this testing and evaluation we need to go over, and we're trying to work on your symptoms and approach. So 2 to 8 weeks is typically our follow-up, depending on what is going on. Now, what about return patient visits? So again, on a yearly basis, we need to evaluate for sudden cardiac death. So that's your EKG, that's your event monitors, those types of things. Guidelines say every 3 to 5 years to repeat imaging. So we keep monitoring track of that for echoes and MRIs. And then importantly, we talk about your symptoms and what's going on with you now. Do you feel like your current treatments that you're having are improving your quality of life? If so, that's great. And we extend out your visit. If you feel like your current treatment is not improving your quality of life, then we talk about our options, which can be adjusting your medications. We can look more at imaging to see if anything has changed from before. We can also talk about those referrals to surgery and electrophysiology and transplant evaluation if necessary. And follow-up then is dependent on symptoms. So for example, I have a few patients who do not have any symptoms, who every year during their sudden cardiac death risk evaluation, it turns up fine. And so we see them on a yearly basis. I have other patients that we're currently working through what their treatment is to be able to improve their quality of life. And so we see them a lot more frequently than that. And so it really is patient dependent for follow-up. The other thing though that we can offer is specifically if those other treatments don't seem to be working. So the medications aren't still improving the quality of life to where you want them to be, or we've done surgery or ablation and you're improved or you're still not getting the quality of life that you need. We also have research going on here at the University of Utah, which is an advantage here. What I have listed on the screen are 3 trials that we've been involved in, 2 of which are that medication called mavacamten that Dr. Weaver Pinzone went over, and one of which is to answer that question that we get asked by lots of our patients is how much exercise is too much for somebody who has hypertrophic cardiomyopathy? So right now we're in the follow-up phase of that trial, so we still don't have the full answer to that, but these are some of the trials that we've been able to participate in, and there's more coming in the future. So that's an option as well, especially for those patients where we've exhausted other forms of treatment. Now, what is going on behind the scenes? I have a few individuals put up on the screen here. I could not do my job without them. So these women are working tirelessly in the background to be able to help our clinic flow. So Sharon Ugolini is our program developer. She tries to find ways to make our clinic more efficient, to run more smoothly, to make our processes go faster. And we're so grateful for her. Our 2 nurses, Deanne Monson and Judy Bolton, they do so much for our clinic. They are able to speak with patients who call in who have serious questions about symptoms or health problems that are going in, and then they can contact myself and Dr. Weaver Pinzone right away. They triage patient needs, they go over labs, Without them, I would not be able to do my job. Our patient diagnostic assistants as well, they do scheduling, they take patient phone calls and get them to who they need to go to. They communicate with our patients through MyChart and email. So this team in the background really is how we're able to get everything done and to be able to be as organized and everything as the program is. So I'm so grateful for them on our team. Educational efforts, that's also a part of our clinic and also part of what we do at the University of Utah. So patient-wise, patient education. In clinic, we try to go over a lot of education. Again, your first visit with us is pretty long because of what we do in terms of education and symptom-wise and learning about your history and going on from there. We're also currently developing a support group. So not quite yet up and ready, but it will be here. But from what Lisa has said during her slides too, the HCMA will have that available soon, within 48 hours of when someone calls them, which is absolutely incredible. So we'll have that option too for patients is through the HCMA. Also, we educate the staff at the hospital. We want our nurses, we want our MAs, we want our residents and our advanced practice clinicians, our doctors to all be aware of this condition. And so Dr. Weaver-Pinzone will do grand rounds, we'll do, teach our fellows and do a lot of educational efforts there as well. And then community outreach. So Dr. Weaver-Pinzone has also done grand rounds talks at places in different states to be able to educate one about what we do here at the University of Utah and about this condition just in general. And then we do a lot of CME talks as well. So for example, one of those is last month, there was something called Oktoberfest, where there was an outreach opportunity where Dr. Weaver-Pinzone and Dr. Salzman also spoke about hypertrophic cardiomyopathy and treatment options. So again, this slide Dr. Weaver-Pinzone had, but it's our team. Without our entire team, we would not be able to have this clinic function and run. There's a lot of people I didn't talk about already, but there's a lot of people behind the scenes that help us to be able to make this possible. And then in conclusion, again, we are a designated center of excellence through the HCMA. We see patients from 7 different states. So, the Intermountain West, and to do that, we do in-person and telemedicine visits. This requires a large team to coordinate our patients' care. We pride ourselves on using evidence-based medicine to treat our patients, and we also have access to clinical research trials for you as well. At the bottom too, in just again, ways to contact our clinic, to either for an appointment or to get more information. There's our phone number, the email address, and then the website listed below. All right, thank you.
Thank you very much. And remember, when you're running your in-person support group meetings after COVID disappears and leaves us alone, to make sure that you're communicating with our office so we can put it on the HCMA calendar as well. So patients who may not have heard about it through you will hear about it through us. So let us help you promote this. Okay, Ivana. When we started this meeting, I said, could you please pronounce your name for me? And that was like 2 hours ago. And there's lots of, consonants in a row, and that always gets me. So I'm going to introduce Ivana, and she's going to tell you how to pronounce her last name correctly, because Lisa gives up. It's late in the day here, and I've had a heck of a week. So Ivana, would you please talk to us a little bit about genetic testing in HCM? And it's all you, my dear.
Thank you. And, even on a normal day, it's a difficult name to pronounce. So let me go ahead and share my screen. All right. Thank you all. I'm excited to be here today to talk with you. So my name is Ivana, and my last name is pronounced Grbelia. So for anyone that wants to practice that later. And I'm going to talk today a little bit about genetic testing in hypertrophic cardiomyopathy. So some of the topics that I'm going to cover today, so I'm going to just review some of the basics of HCM genetics. I know we have a number of different groups on here, and I'll also talk through what your experience would be if you are getting genetic counseling and genetic testing at our center. I'm going to use a case example to talk about some of the main benefits that we might see with genetic testing. and also some special genetic testing considerations. So some points that you might want to think of before proceeding with genetic testing, and some common questions that I get. All right, so some of this information has already been mentioned today, but as a reminder, HCM is typically inherited as an autosomal dominant pattern. So meaning that a person that has HCM has a 50% risk of passing on a mutation to each of their children. And it's important to remember that we do see variability even in the same family. So we might have some family members that have had more severe disease, maybe needed a transplant or had a cardiac arrest, and other family members might have no symptoms at all. As well, some family members may never go on to develop the condition in their lifetime. We do see that as well. And the age of onset can be variable. One limitation, unfortunate limitation that I want to point out when it comes to genetic testing is that for HCM is that unfortunately the diagnostic yield is not 100%. So what this means is we don't know at this time, we don't know all the genetic causes of HCM. So probably in about half of our families, we will identify a cause, and then unfortunately the other half we won't. For those genetic causes that we do know about, the MYBPC3 and MYH7 genes, so two sarcomere genes, are the majority where we identify genetic mutations. And another important factor to remember is that while this is a small proportion of patients, in about 5% of patients with HCM, we will identify 2 or more variants. So when you're going through the genetic process, what can you expect in terms of what your test is looking for and what you might find on the report? So Lisa mentioned at the beginning that so we know of the genes, sarcomere genes that can cause HCM, but there are also genetic conditions that can mimic HCM. And nowadays, as our panels have gotten bigger, we are able to test for both types. And really what's very important is the classification of the variants that are identified or genetic changes that are identified on the genetic testing. And here we have 3 main categories as to what might show up on your report. So if I'm seeing somebody who has HCM and we've completed genetic testing, if they come back with a positive result, what that means is that a likely pathogenic or a pathogenic, at least one was identified on the genetic testing. And this is quite useful in terms of what we can do for family members, and I'll explain later a little more of that information. On the flip side, somebody who has HCM may come back with a negative result. Again, this doesn't mean that it's not genetic. Very likely it's that our technology is not good enough at this point to identify what that person's cause was. And then we have a third category, which is a question mark. So these are what we call variants of uncertain significance. And I would say it is relatively common when we're doing genetic testing that we identify 1 or more of these uncertain variants. And the reason for that is because our panels are getting bigger. We're able to look at more information, and as a result, there is still information that we haven't been able to classify or we don't know the significance. It's important to be mindful when we're looking, when we do find a variant of uncertain significance. We don't want to be, in most cases, we don't want to make any medical management decisions based on the presence or an absence of an uncertain variant. In most cases, when we do test family members for an uncertain variant, it is to help with the reclassification process. And this unfortunately can take several years. So it's good to check in with us, every year, every couple of years to see if there's been any updates. But again, be aware that this process can take years. So a summary of what your experience might be if you're having genetic counseling or testing at our center. So nowadays in the COVID era, a lot of my sessions are telehealth. Genetic counseling lends itself well to telehealth. And so in pre-COVID eras, I would be there in the clinic and it would be something that we could offer the same day. And we break it up into 2 sections. So we have the pre-test counseling session. And this is where I go over your medical history, evaluate your family history. It's very important that we get a good family history. I ask about any concerning symptoms that might point us to potentially other family members maybe having early signs of HCM. And a large portion of our the session is patient education, and it can really depend. You know, some people, they're coming in and they've had this diagnosis for a while, and others, this is all very new information. And so we try to meet the patient where they are, and we go over some of the genetics of HCM, the specifics about testing, what each result can mean for both yourself and your family members, and we try to address questions that patients might have. And in particular, two common questions tend to be the cost of the testing and then concerns regarding genetic discrimination. Now, if somebody wishes to go ahead with testing, we then obtain consent and coordinate the test itself. Once the test results come back, I review that with my team and then also call the patient to discuss the result. And we talk about next steps for themselves and their family members. A very important part of having a genetic counselor involved is helping with family communication. So let's say if somebody is positive, the next step is how can we best communicate that information to their family members and also help them get that testing as well. So one way that I do that is by creating letters to share with family members, proband can share with their family members, and that includes all the information they would need to be able to pursue genetic counseling and testing. And one thing I want to say, especially for family members that are maybe all over the country or maybe live in rural areas, if you're not able to see our center, there are genetic counselors that do telehealth as well. And so don't worry if you're not in Utah or in Idaho or in one of the states that we take care of. There are a lot more options nowadays for getting this service as well. So I want to quickly dive into an example, and this is actually an example based on a couple of different families that I've had, just a couple of important points that I wanted to illustrate about the genetic testing process and the benefits of genetic testing. So here's a patient that came in that was recently diagnosed with HCM, and took a family history, and there was no significant family history. And I will say that this isn't uncommon for me to take a detailed family history, and really there's no concerning signs or other family members with HCM. And you can imagine some of that might be because there could be family members that have HCM and potentially they don't know it. Another reason might be that people sometimes don't share their family history information. So this important point to remember when you get together with your families, this year more likely to be virtually, but to share some of this medical information. So even though this is the only person in the family that we know of at this point that has HCM, we still recommend genetic testing. And in this case, this person came back positive for a pathogenic variant in MYBPC3. So our next steps there are to recommend genetic testing for first degree relatives. So in this case, this person's child and their parents. But in this person's history, we can see that they have a sibling that's passed away. And so we now can also offer the testing for this person's nephew. And so this is what we might see in a family that's gone through the process of genetic testing. And I'm going to break this up in sections of the pedigree, starting with the proband's child. So you can see they came back positive for a pathogenic variant, or for the same familial pathogenic variant. And what was interesting was when they went in for their cardiology visit, they were actually found to have HCM. And in this person's case, it was quite mild. So that was a good thing that we were able to catch it early. Now, this patient's parents were also tested. And traditionally, when genetic testing used to be more expensive, we might have tested first one parent, and then if they were negative, moved on and tested then the other parent. But what I want you to know about nowadays is that some labs do offer family variant testing free of charge in a certain time period. So sometimes it's actually nowadays it's more efficient if we can to test both parents at the same time. And in this case, this person's mother was positive and no signs of the condition, no diagnosis of HCM. And this is something that I have seen time and time again in my experience as a genetic counselor, is that we do identify family members, even older family members, that do not have signs of HCM. What was another point I'd like to mention here is that with the genetic testing, we were able to test multiple family members, including more extended relatives to the proband. And an interesting one was this cousin of the proband who was positive on the genetic testing. And when they went in for their cardiology visit, they were actually, based on their evaluation, they were found to be high risk of having sudden cardiac arrest. And in the end, what was recommended was an ICD placement. So this was somebody that didn't know they had the condition, although close to the time that they had the appointment, they had experienced some symptoms of fainting. And so the question is, again, this is a more extended relative. That's information that maybe, if you're not seeing these relatives very often, you maybe don't know about some of these symptoms that they're having. So to summarize from that example, cascade genetic testing can be utilized if we identify a disease-causing variant in the family. And as was shown in this particular case, it can help with early detection of HCM, and it can also help for earlier interventions. And in this case, with that one family member, it was quite fortunate that we caught it when we did. Now, ongoing HCM screening is not needed for relatives that test negative for the familial pathogenic variant. For those of you who live in Utah and surrounding area, you know that we have lots of big families here. And so when we identify a genetic disease-causing change, one positive is that we can release some family members from screening. And then one other thing I just want to quickly mention is the potential for being able to use pre-implantation genetic diagnosis. This is for family planning, and this is an interesting technology that certainly has its barriers, but when we know the genetic mutation that's in the family, then people can use this technology to test embryos and only implant embryos that do not have the familial mutation. And as I said, there are certainly barriers, and some people may not feel comfortable with this type of technology, but it is something that becomes available once we know the mutation. And as you can see from this example, a lot of our benefits of genetic testing are for the family members. And hopefully as our knowledge and technology advances, we can learn about treatments that we can potentially tailor towards somebody's specific genotype. Not quite there yet, but hopefully something that we can do in the future. So hopefully in the future, there'll be more benefit even to our probands. Something I want to quickly touch on is some clinical screening guidelines for HCM. And here I've included one of the more recent guidelines that have been published. So this is from the Heart Failure Society of America. It's a 2018 guideline. And it lists out suggested screening intervals for first degree relatives of somebody with HCM with no identified mutation, or for asymptomatic family members that are positive. And note that previous guidelines have had similar, have said similar things. Some of the differences might be the age at which we should start screening. And the exact intervals or the exact age where you start screening potentially might vary based on what center you're seen with. And sometimes we do need to use our clinical judgment and looking at, if we have a family history that we have multiple family members affected, we need to not just fully rely on these guidelines, but again, these are suggested guidelines. What I'm hoping, and I think a lot of us are hoping for moving forward, is that we're going to be able to learn information that will help tailor a risk assessment for our families. So one study that I wanted to bring your attention to, this is a paper that was recently published, and it was looking at the penetrance of hypertrophic cardiomyopathy in sarcomere protein mutation carriers. Now, this was an interesting study because it it followed 285 individuals from 156 families. So the way it was set up was these individuals were positive, so they had a familial mutation, but they were negative. They did not have a clinical diagnosis of HCM on their first screening, and so they were followed over a 15-year period. And about half of the participants developed HCM over that 15-year follow-up period. And so what this study was able to do was look at what were some of the risk factors for developing HCM in that time period. And they found that males were more likely to develop HCM over that time period. Another something interesting that they noted was that at that initial negative screen, those that had an abnormal EKG were at higher risk over this time period to develop HCM. They were also able to look at the risk based on mutations in specific genes, so that they found that the highest penetrance seemed to be in MYBPC3 and MYH7, whereas the lowest penetrance seemed to be in mutations in TNNI3. So to cover some of the very common questions that I get as a genetic counselor is, number one question is, what is the cost of testing and will my insurance cover it? So I'm happy to say that this testing has become more available for people over the years, especially in recent years. And patients do have multiple options available when they're pursuing genetic testing. So we can go through insurance, and at least in my experience, I find that insurance coverage for HCM seems to be decent, maybe even a bit better than some other conditions that I see. But that being said, if insurance doesn't cover the testing, then there is a patient pay option, and some labs offer genetic testing for HCM for as low as $250. Now, I know $250 can still buy us quite a bit, but I say it's relatively low because genetic testing, even a few years ago, used to be thousands of dollars. So the fact that you can get this testing that used to cost thousands of dollars for a couple of $100 is quite remarkable. And now at this time, I don't know how long this will be available, but at this time, there is a sponsored no-charge genetic testing program through Invitae. So if you have HCM, you do qualify for this testing program. So again, there are multiple options for patients with HCM nowadays. Something else I'd like to mention is that a lot of the genetic testing labs do offer patient assistance programs and or payment plans. So even if you don't want, the sponsored testing, if you're worried about doing the sponsored testing and it's going to be a high cost for you, there might still be some options we can look into. And then lastly, I also want to talk about the Genetic Information Non-Discrimination Act, or GINA for short. And another common question I get is, will genetic testing affect my ability to keep health insurance? What about life insurance? So I can say, luckily, thanks to GINA, we do have some protections available. So this law protects people, it prohibits health insurers and employers from discriminating against a person based on their genetic information. So for example, their genetic information can't be used to determine eligibility for health insurance, and an employer can't make employment decisions based on someone's genetic information. Now, GINA, this covers most people, though there are some exceptions. Unfortunately as well, GINA does not cover life insurance, long-term care insurance, or disability insurance. So these are entities that can ask about your genetic information, and they can make decisions based on that information. And hopefully in the future we move towards where we'll have protections for life insurance as well. But at this time, we're not quite there. Another important point that I would like to mention is postmortem genetic testing. So if you have a family member that has passed away from HCM and genetic testing wasn't available at the time or wasn't done for whatever reason, there is a potential that genetic testing can be performed on a sample after somebody has passed away. Now, we prefer a blood sample, but that's not always the case. Even if we haven't gotten a blood sample, postmortem genetic testing may be available. There are other samples such as a blood spot or frozen tissue that we can try to complete genetic testing on. Unfortunately, blood spots, for example, it's much more difficult to perform genetic testing on that type of sample, and only some labs might accept the test, or might accept the sample, and the testing itself might be limited. But I can say that I have had some success on samples outside of blood. So that's something to keep in mind, and hopefully in the future we'll be able to educate better about when someone does pass away, having the proper sample on, kept. In terms of genetic testing and counseling during this COVID-19 pandemic, it's actually logistically hasn't been too bad. So the labs, they have some great services that they provide now for patients. We have the ability to send either a cheek swab or a saliva kit to a patient's home. And for some patients, depending where they live, they might even be able to coordinate at-home phlebotomy. So the lab sends out phlebotomy to their house. and can handle the blood draw that way. And if you're doing a saliva sample or a cheek swab, it comes with everything that you need to ship the sample back, so prepaid label and packaging. And lastly, I just want to end this talk by letting you know how you can have a genetic counseling appointment at our center. If you are being followed already in our HCM clinic, then this is something that will be offered or would be offered. But if you're someone on our on this presentation today that is a family member that's trying to get testing, or if you're a provider that maybe has patients that you want to refer for genetic counseling and testing, this is one way that you can do it. So I've included the phone number for scheduling, so directly scheduling genetic counseling, and our the fax as well. And I know the contact information that Holly provided can be used as well. So with that, I'm going to stop sharing my screen and pass it back to Lisa. Thank you. Oh, Lisa, I think you're on mute.
Here. I hit the wrong button. I was on mute again. So I was saying thank you for hitting all of the top topics that I always go back to at the end of these presentations. Invitae's genetic testing program and what GINA covers and what GINA doesn't cover, and just going through all those really important thought processes that people need to consider when they're looking at genetic testing, and how the evolution of genetic testing has just blown me away. I remember in 2000, I think 4 or 5, when the first clinically available genetic test hit the market for HCM. I think it was $8,000 when it hit. And I said, I'm going to beat them up until it's affordable. And I think we actually did that. I don't know if there's a lot of bruises out there on some industry folks, but I'm probably responsible for a few of them. Okay, I'm going to have the panelists unmute their mics, all of our University of Utah folks. If you have any questions that have not been answered already, we're going to address them now. I am going to go back and read through a couple of the ones that we did respond to in writing already, while you're all in your little chat boxes, or in your Q&A boxes, I should say, and typing in any additional questions that you might have. There was a lot of questions about mavacamten, and I want to be very clear and say mavacamten is an investigational drug at this time. It is not approved by the FDA, and we do not know when, and frankly if, but it's probably a when, it will get approved. So I know a couple of you asked some questions about when can you get it? And the answer is absolutely nobody knows the answer to that question. Myocardia was given an offer by Bristol Myers Squibb. I don't know if you heard about this or not. They were bought for $13 billion. So I think somebody sees something there that might be, profitable for somebody, which might mean useful for us. So if $13 billion speaks to you, I think you might have an understanding of whether or not that's going to hit market or not. So, but it's not out there right now. So that's one question that I wanted to go over. Somebody asked about robotic surgery, and Craig, I'm going to tap you on that one. I know Cleveland is doing some robotic HCM surgery, but mostly at the level of the mitral valve. Can you explain why robotic surgery sounds good on paper, but in HCM it's a little difficult practically?
Well, thanks. I think there's also just a general, misunderstanding about heart surgery. People think heart surgery is open heart surgery, and so you can't get to this real estate, this pricey real estate, without opening up a structure to get inside. So by definition, it's open heart surgery, as opposed to bypass surgery, which is not open heart, where you put a new bypass graft on the surface of the heart. The robot is awesome for a lot of things, in particular the mitral valve. And I had that one slide where I showed an approach through the mitral valve to get to the septum. And that's a good way to do it robotically, because you can take that down and it's right there in front of you. The exposure looking down through the aorta is a little challenging through a video camera, especially the way that the aorta is kind of it's in a different direction that a video camera can't quite get to. So I think there's a lot of different ways to get inside the heart in terms of from outside the body. And a lot of people think that, hey, a robot is not open heart surgery. Actually, a robot is open heart surgery. It's just not necessarily opening up your breastbone to do it. Traditional heart surgery is opening up your breastbone. There's a lot of different ways to get to the heart without doing that necessarily. I think the robot has there are zealots, and then there are folks that have picked it up and then no longer do it. I think there's probably a happy medium with heart surgery. The robot's been great for a lot of things. If you need your prostate taken out, get it done with a robot. But heart surgery, it's not fully out there. But I think your point is a good one, Lisa, that there's only certain parts that you can navigate within the heart, within the robot. And a more traditional approach gives you a lot more flexibility on how you can approach the operation. And then the last thing I put in that comment is that the most important thing is to have a safe and effective operation. Those are the two things that you really need. So
I couldn't agree more. We have an interesting question here, and I just want to just do a programming note here. In about 5 minutes, we're going to stop streaming on Facebook, and we're going to stop recording, and we're going to allow people to raise their hand to ask verbal questions if they wish. That will not be recorded, that will not be put on the internet later, that will not be streamed on Facebook. So if you want to ask a verbal question, you'll have the opportunity to do so in a few moments. So the question coming to us now is, I've had an ICD implanted. Is it possible that it has stopped 3 episodes of AFib within a few seconds? I've had paroxysmal AFib that normally lasts for 18 hours. Dr. Bunch, does an ICD stop atrial fibrillation?
It can. It's not designed to. It's designed to treat the equivalent in the bottom chambers, ventricular fibrillation. So typically, if it stopped your atrial fibrillation, it shocked you from a worse rhythm in the bottom chamber. But it's not otherwise designed at all to treat the upper chambers. So but it does track it very well, and people with ICDs have a monitor that informs us of early detection, sometimes even before they have symptoms of atrial fibrillation. So they're nice in that regard.
I remember way back when they were trying to create an ICD for AFib that you could shock yourself.
Yeah. So that was in my training, and you were shocked all the time. So nobody wanted to be shocked, or nobody wanted to shock themselves or be shocked all the time. That's why we no longer see them, because it's not a life-threatening rhythm that you want to be shocked for.
I never thought that was a really bright idea, but
No.
somebody thought, hey, we'll
I
just
do
cardio
remember
them at home on their own with a little Ambien or something. No.
Yeah, exactly.
No, I don't think that was a great idea. Okay, so we have no other questions in the queue right now. I am going to thank our viewers on Facebook for sticking with us for a long Facebook kind of an episode here. All these meetings are a little bit longer for Facebook, but people pop in and out of those, and I encourage them to come back and revisit and share with their friends and family. So thank you to Facebook crowd. You are now stopped. They're gone now. It's just us. So Facebook is gone. If anybody has any questions that they would like to raise their hand with, let me know. I'm going to hit the end on record here. So you're going to get a little notice.